Doc, may concern lang po. Si PGI Montes po yung last reporter po for today. Nasa biyahe pa po ata siya. Galing po siya sa appointment niya sa DFA po.
Okay lang, sabi ko naman kasi initially 2 o'clock, di ba?
Opo. Pero okay lang po, last reporter naman po siya. Baka po
Ano na lang siya, pakinigin mo na lang muna. Open
Okay
mo.
po. Sige.
Alright. So let's start.
Doc, pwede na po mag-share screen.
Pwede na ata.
Okay po. Pwede na nga po. Kita na po, Doc.
Sige, go ahead. Go
Okay po.
ahead.
So, good afternoon, doctors. I'm PGI Baron and I will be presenting a case of vaginal birth after cesarean delivery. So, this particular patient was admitted last April 8, 2021. So, patient CD is a 28-year-old G2P11001, pregnancy uterine, 39 and 4/7 weeks age of gestation by ultrasound, cephalic in labor, previous cesarean delivery for breech presentation last 2017. So she came in due to the chief complaint of hypogastric pain. So for the patient's past medical history and family history, it was noted to be unremarkable. For the personal and social history, the patient is a non-smoker, non-alcoholic beverage drinker, unemployed, cohabiting with a 28-year-old sales clerk for 7 years now. So the patient's menarche started at 13 years old with regular cycle, lasting for 5 to 7 days duration, consuming 3 to 4 moderately soaked pads with no dysmenorrhea or other associated symptoms. So Poetarch started at 23 years old with one sexual partner, no history of oral contraceptive pills use, and um, the and no history of pap smear done. So on the obstetric history of the patient, G1 was a live term girl delivered last 2017 via primary cesarean section for breech presentation at Fabella Hospital. The birth weight is 3,000 grams and there was no fetal-maternal complications. The G2 of the patient is her current pregnancy with noted LMP of July 5, 2020. However, the patient said that she was not unsure about this LMP. So the age of gestation was based on the estimated date of confinement from the earliest ultrasound. So the patient was asked to remember her EDC of April 11, 2021, and the computed age of gestation is 39 and 4/7 weeks. So for the history of the patient, she missed her menses for 4 weeks, and then that prompted her to take an at-home pregnancy test, which revealed a positive result. This prompted her to consult in a nearby lying-in clinic where transvaginal ultrasound was requested, and she was prescribed with folic acid 1 tab once a day. However, the patient did not undergo transvaginal ultrasound. So the patient had two Jonetta OPD checkups, prenatal checkups, which were unremarkable. And then at 15 weeks age of gestation, she consulted again at the Jonetta OPD, and this was noted to be her earliest ultrasound. Labs were requested during this time, like CBC, urinalysis, transvaginal ultrasound, and VDRL test. So the transvaginal ultrasound done this day revealed intrauterine pregnancy and was unremarkable. At 22 and 1/7 weeks age of gestation, another follow-up checkup with the baseline result of the baseline laboratories were given. So lab results shown, according to the patient, the lab results were all within normal limits. And then the patient was advised to do a 75-gram OGTT at 24 weeks age of gestation. So on her next follow-up checkup at 26 weeks age of gestation, the patient um, informed that the result of her 75-gram OGTT was normal. And then the patient had total of 3 Junelta OPD prenatal checkups, which were all unremarkable. And the last ultrasound of the patient was done at 35 and 5/7 weeks age of gestation, revealing an estimated fetal weight of 2,900 grams. Until 1 day prior to admission, or at 39 and 3/7 weeks age of gestation, the patient experienced hypogastric pain, which prompted her to consult the ER. So the patient had associated uterine contractions, which were noted not occurring in 20 minutes, no vaginal bleeding, and no watery vaginal discharge. On assessment at the ER, speculum exam was done, revealing that cervix is pink, smooth, with minimal bloody mucoid discharge. On internal examination, the cervix is 1 cm dilated, beginning effacement, intact bag of water, cephalic, floating. So the patient was then referred to a Jonelta consultant, and she was advised to be discharged. Along with this, a request for RT-PCR was given. Also, she was asked to continue fetal movement counting, take her prenatal medications, and watch out for active signs of labor. Few hours prior to admission, at 39 and 4/7 weeks age of gestation, the hypogastric pain, hypogastric pain persisted. So it is now noted with increased intensity with a pain scale of 7 to 8/10 with regular uterine contractions, still no watery vaginal discharge and vaginal bleeding. At the assessment at the ER, the vital signs are as follows: 90/60 millimeters mercury, 90 beats per minute, 20 cycles per minute, a febrile at 36.4 degrees Celsius. Uterine contractions were occurring every 6 to 7 minutes, moderate, lasting for 50 to 60 seconds. Funded height is 33 centimeters. Fetal heart tones is 130s, and the estimated fetal weight at this time is 3,200 to 3,400 grams. On speculum exam, cervix is pink, smooth, with bloody mucoid vaginal discharge, no watery discharge. On IE, cervix is at mid position, soft, 5 cms dilated, 70% effaced, intact bag of water, cephalic, and station -3. And then pelvimetry was also done and revealed adequate. So the plan for the patient is for her to be admitted for vaginal birth after cesarean. So we have an impression of G2P1 1001 pregnancy uterine, 39 and 4/7 weeks age of gestation by ultrasound, cephalic in labor, previous cesarean section for breech presentation last 2017. So admissions test was done upon the arrival at the labor room. So the admissions test revealed a category 1 trace. So we have a baseline heart rate of 135 to 140 beats per minute, moderate variability with accelerations and no decelerations, with good fetal movements noted, uterine contractions occurring every 3 to 4 minutes, moderate to strong, lasting for 50 to 60 seconds. So on IE, the cervix is 6 cms dilated, 80% effaced, intact bag of water, cephalic, and at station -3. So this is the tracing during labor, which revealed again in category 1 pattern. So we have here a baseline heart rate of 135 to 140, and then we also have moderate variability with accelerations and no decelerations. Uterine contractions is every 2 to 3 minutes, and then it is moderate to strong with lasting for 50 to 60 seconds. So this tracing revealed category 1 pattern, which is considered normal, and it indicates minimal likelihood of significant metabolic acidemia and ongoing fetal hypoxic injury. So we could say that tracing is a category 1 pattern if the baseline fetal heart rate is at 110 to 160 beats per minute. The variability is moderate, meaning there is 6 to 25 beats per minute, and then there is no late or variable decelerations. Early deceleration may or may not be present, and accelerations may or may not be present. So next we have the partograph during labor, and then on the first hour of labor, the dilation is the cervix is 5 centimeters dilated, and then the station is at -3. On the second hour of labor, the dilation is now at 6 centimeters, and then still at -3 station -3. On the fourth hour of labor, the cervix is now almost fully dilated, 8 cms po, and then station positive +1, station +1. So on the fourth hour of labor, there is noted spontaneous rupture of membranes, and on IE, cervix is fully dilated and effaced with ruptured bag of water, cephalic, station +1. So the patient was then delivered via vaginal birth after cesarean, vacuum assisted with right medial lateral episiotomy and repair of second degree laceration. The outcome is a live term boy with a birth weight of 3,856 grams, birth length of 53 centimeters, Apgar of 99, Ballard score of 39 weeks, large for gestational age. So the patient was then transferred to PAHO for monitoring. So vacuum extraction was done due to maternal exhaustion. So the according to doctors, matagal daw po mag-bear down si patient.
Is
So
vacuum extraction done just because of poor maternal effort?
there are other factors po which will be discussed at the
Alright.
end. Okay po. So our final diagnosis is G2P2 2002 pregnancy uterine delivered live term boy with a birth weight of 3,856 grams, birth length of 53 centimeters, Apgar of 99, Ballard score of 39 weeks, large for gestational age, via vaginal birth after cesarean delivery, vacuum assisted with right mediolateral episiotomy and repair of second degree laceration, previous, previous cesarean delivery for breech presentation last 2017. So for our discussion, women with history of cesarean delivery have two fates or options for mode of delivery in their subsequent pregnancy. Either they attempt for TOLAC or trial of labor after cesarean section with a goal of VBAC or vaginal birth after cesarean, or they can undergo ERCD or elective repeat cesarean delivery, which can be scheduled or unscheduled but planned. So the ultimate decision should weigh clinical factors known to influence the TOLAC success as well as the benefits and risks. So what are the factors that influence a successful TOLAC? So we have factors that are low risk. transverse incision, prior vaginal delivery, appropriate counseling, and sufficient personnel and equipment. For factors that favor success, we have teaching hospital, white race, spontaneous labor, prior fetal malpresentation, one or two prior transverse incisions, non-recurrent indication, current preterm pregnancy. For factors that may increase failure rate, we have single mother, increased maternal age, macrosomic fetus, obesity, breech presentation, multifetal pregnancy, preeclampsia, estimated gestational age of more than 40 weeks, no vertical incision, no unknown incision, labor induction, medical disease, multiple prior cesarean deliveries, education of less than 12 years, and short inter-delivery interval and liability concerns. For factors that have high risk, we have classical or T incision, prior rupture, patient refusal, transfundal surgery, obstetric contraindications like previa, and inadequate facilities. So in our patient, we have she had previous transverse incision. She has now spontaneous labor, prior fetal malpresentation, and there is non-recurrent indication. So for both TOLAC and ERCD have risks and benefits to the mother and the fetus. So first we have for the maternal risk, there under TOLAC there is risk of transfusion and infection um, significantly greater in women attempting TOLAC as well as the uterine rupture as compared to those who will undergo ERCD. But the risk of maternal death is significantly reduced with TOLAC than with ERCD. So for the fetal and neonatal risks, there is an increased risk for perinatal and neonatal mortality during TOLAC, and it is also associated with higher risk of hypoxic ischemic encephalopathy. And then for the ERCD, there is absolute risk for transient tachypnea of the newborn, which is higher, and as well as the birth trauma from lacerations. But there is no significant difference in the 5-minute Apgar score or NICU admission rates between both the procedures. So who can be candidates for TOLAC? So first, women with only one previous low transverse incision have the lowest risk of symptomatic scar separation. So here we are presented with the types of prior uterine incisions and estimated risks of uterine rupture. Um, the highest risk are those with the highest risk are those with prior vertical incisions extending to the fundus. Specifically, a classical wrist may rupture even before labor onset. So the classical and T-shaped uterine incisions are considered as absolute contraindication for trial of labor. So there is a doubling or tripling of the rupture rate in women with two compared to one transverse hysterotomy. Having multiple uterine scar or two or more prior cesarean delivery is a relative contraindication for trial of labor. And to predict likelihood of rupture, sonographic measurement of a prior hysterotomy incision may be done. So the thickness of the lower uterine segment is a strong predictor for a uterine scar defect in the women with prior cesarean delivery. The segment is defined as the smallest measurement between urine in the maternal bladder and amniotic fluid. So in a systematic review by Jastro, lower uterine segment thickness were sonographically measured between 34 to 39 weeks age of gestation. They were able to categorize risks into high, intermediate, and low, with the segments measuring less than 2 millimeters, 2 to 2.4 millimeters, and more than or equal to 2.5 millimeters, respectively. Next, we have no prior uterine rupture. So this gives greater risks for, because prior uterine rupture gives greater risk for recurrence. It is also one of the absolute contraindications for trial of labor. So here. And then next we have interdelivery intervals of 18 months. So um, less than or equal to 18 months are associated with threefold greater risk of symptomatic rupture during a subsequent TOLAC compared to those with intervals of more than 18 months. So there are MRI studies of myometrial healing that suggests that complete uterine involution and restoration of anatomy may require at least 6 months. For the next factor, we have prior vaginal delivery. This may either be before or after the cesarean section. This improves the prognosis for a subsequent vaginal delivery. It also lowers the risk of subsequent uterine rupture and other morbidities. Number five is indication for the first cesarean section should not be due to CPD or cephalopelvic disproportion. So when women with non-recurring indications have the highest risk of nearly 90% success. And then number six, fetal size of less than 4,000 grams. So it is said that increasing fetal size increases the risk of uterine rupture with 1% for those less than 4,000 grams, 1.6% for those more than 4,000 grams, and 2.4% for more than 4,250 grams. An increasing birth weight is associated with elevated risk for failed trial of labor, shoulder dystocia, and perineal laceration. Next is multifetal gestation. So twin pregnancy does not appear to increase the risk of uterine rupture. And then we also have maternal obesity. There is an inverse relationship between pre-pregnancy BMI and VBAC rates. So 85% with those with normal BMI, 75 with BMI between 25 to 30, 70% with BMI between 30 and 40, and 61% with BMI of more than or equal to 40. So in our patient, she has only one previous transverse incision. She had no prior uterine rupture. The interdelivery rate, interdelivery interval is more than 18 months since she gave birth at 2017. And then there is the indication for her first cesarean section was not due to cephalopelvic disproportion. Instead, it was because of malpresentation or breech presentation. And the fetal size is not more than 4,000 grams. So we also should take note that some of the criteria for a um, TOLAC or VBAC is that the presentation should be cephalic. There should be clinically adequate pelvis, and then the birth weight preferably should be less than or equal to the previous baby, and then there should be availability of physicians, facilities, and adequate anesthesia for emergency cesarean in case the TOLAC is failed. And then, of course, we should also have consent of the patient. So, labor and for the labor and delivery considerations, first we have timing. It is recommended that we delay non-medically indicated deliveries until 39 completed weeks age of gestation or beyond. And then for the intrapartum care, the trial must be done in facilities with staff immediately available to provide emergency care. So we also have cervical ripening and labor stimulation. Labor induction is associated with a higher failure rate. So augmentation using oxytocin or prostaglandins may increase the rate of uterine rupture. So for the epidural analgesia, this might mask the pain of uterine rupture. And then we also have uterine scar exploration. So some clinicians, they routinely document the integrity of the integrity of a prior scar by placing a hand through a dilated cervix along the inner surface of the lower uterine segment. The cervical evaluation is unnecessary unless the patient is symptomatic. So, surgical correction of a dehiscence is necessary if there is significant bleeding. So, what is uterine scar rupture? So, the rates of uterine rupture are increased with TOLAC, but the absolute risk is low. On a systematic review by Geese and colleagues, it is concluded that the risk was significantly elevated in women undergoing TOLAC with a absolute risk of 0.47%. So, this may be classified as complete when all layers of the uterine wall are separated, or incomplete when uterine muscle is separated but the visceral peritoneum is still intact. This may also be called uterine dehiscence. So, the most common sign is a non-reassuring fetal rate pattern with variable decelerations that may evolve into late decelerations and bradycardia. Patients may experience cessation of contractions following uterine rupture, and clinical presentation may mirror that of placental abruption. And pain or tenderness may or may not be appreciable. The condition that usually becomes the condition usually becomes evident because of fetal distress and maternal hypovolemia from concealed hemorrhage. So with rupture, the only chance of fetal survival, the only chance of fetal survival is afforded by immediate delivery. So no complications like adverse neurological outcomes were observed when delivered in less than 8 minutes from the decision time. So maternal deaths are uncommon in these cases, and for the management, hysterectomy may be required with complete rupture, and suture repair with uterine preservation may also be performed. So, if the patient or if the clinician and the patient decided on VBAC, we have to have counseling even preconceptionally. So women with prior cesarean deliveries may be counseled and given the option of VBAC on their subsequent pregnancies. So there should also be risk assessment, including the documentation of the prior uterine incision and the risks, benefits, and success rates. And for the delivery and labor, there should be cautions for induction, beware of abnormal labor progress, and electronic fetal monitoring pattern abnormalities, and we should know when to abandon trial of labor. So along with vaginal birth after cesarean, uh, operational vaginal delivery was also um, done. So for termination of second stage labor by traction instruments is indicated in any conditions threatening the mother or fetus that is likely to be relieved by delivery. So for in the indications, we have fetal and maternal. So for the fetal indications, non-reassuring fetal heart rate pattern, and premature placental separation. For the maternal indications, we have heart disease, pulmonary compromise, intrapartum infections, neurological conditions, and the most common is exhaustion, which happened to our patient, and prolonged second stage labor. So, and then as compared to forceps delivery, vacuum extraction requires some maternal effort to synchronize with the contraction. It has less expertise required, more incidence of hematoma. It cannot be used in preterm pregnancies. It can be used in partially rotated head. It can only be used in cephalic presentation. Um, it has less maternal injuries but with higher morbidity for infants, and no need for anesthesia, and there is higher failure rate. So some prerequisites engaged head, vertex presentation, known fetal head position, CPD not suspected, fetal weight estimated, experienced operator, ruptured membranes, completely dilated cervix, emptied maternal bladder, no fetal coagulopathy, no fetal demineralization disorder, willingness to abandon operative vaginal delivery, and informed consent secured. So some criteria for good candidates for vacuum extraction are term pregnancies, fetus in occiput anterior position and station +2 or more, or if the fetal head is at or on the perineum. So vacuum extraction, in vacuum extraction, suction is created with a cup placed on the fetal scalp such that traction on the cup aids fetal expulsion. Benefits compared with forceps include simpler requirements for precise positioning on the fetal head and avoidance of space-occupying blades within the vagina, thereby mitigating maternal trauma. So I have here a video of how it is done. Ay, sorry. Okay. So the flexion point is found along the sagittal suture, approximately 3 centimeters in the front of the posterior fontanelle. So this is the posterior fontanelle, 3 centimeters at the front, and approximately 6 centimeters from the anterior fontanelle. So this is the flexion point. And that's all po. Thank you. Doc, naka-mute po kayo.
So in this patient, is poor maternal exhaustion the only cause for a vacuum extracted delivery?
Doc, it was the only, I think it was the only indication po for vacuum extraction.
The fact that the patient was a prior cesarean section, wasn't that, don't you think that is an additional reason
Yes,
why?
yes po Doc, kasi or parang our goal is to prevent the most common complication of VBAC, which is rupture of ano to,
Okay.
uterine rupture po.
One of the ways of preventing rupture is to shorten the second stage of labor,
Yes po.
thereby assisted delivery, be it vacuum, be it forceps. In forceps, in assisted vaginal delivery, so the indications and requirements you have um, adequately discussed. For vaginal birth after cesarean section, the criteria you have adequately discussed. That's good. Those are the things that are questioned very well with regards to this topic, your VBAC. Okay. Um, what are the differences when you manage the patient during delivery? What are the things that you are supposed to do and what are the things that you are not supposed to do? So
Doc, when it comes to labor po, we should not augment or induce.
we should not augment or induce, meaning what should not we use?
Like oxytocin, prostaglandins, and manual.
Some use oxytocin but only half the dose. They would put
Okay.
5 amps, which is a half amp in 1 liter, which is the usual dose. Some would do that, but technically, we do not put inducing agents for fear of in rupturing of the uterine rupture. Okay, what else? What's common practice that you should not do in a VBAC or a TOLAC patient, trial of labor after cesarean patient?
Mm. Mm.
Imagine yourself in the labor room. What are the usual things that we do there that we could do in a normal patient but we should not do in a VBAC patient or in a TOLAC patient? One is oxytocin, that is correct. What else?
Mm.
And you could argue that this is already discouraged even in normal
Doc,
patients.
also the epidural anesthesia po.
Epidural
It is not,
anesthesia, we could do epidural. There's no problem.
but then it could mask po the
It
pain
will
that
mask
could be
your
felt
rupture. Okay.
of uterine rupture po. And
Or you haven't, well, have you heard of your fundal push?
ah, I've seen po pero hindi ko po alam na because it would put pressure po on the
Okay.
uterine scar din po.
You fundal push, it is a maneuver, especially for your older generation, um, that pushes on the an assist pushes on the fundus as to aid expulsion of the baby. And remember, if you have a previous uterine scar and pushing at the inappropriate time could lead to uterine rupture. So when you have a TOLAC patient, you shy away from doing a fundal push. In actuality, fundal push is not recommended anymore,
Mm.
not encouraged anymore, such that the younger obstetricians would not be as adept as doing fundal push as your older ones. But it's still being done, and sometimes it needs to be done. Inabot ko pa siya in training, so it's one of the, lalo na if it's already crowning and kulang na lang ng konti, you aid a little with a nudge. But pushing it when it is a 0 station or a -2, that is not recommended. So you have to time it appropriately, but never on a TOLAC patient. So I hope
Yes po,
that's
Doc.
clear.
Yes, Doc.
Any questions from the other interns? Very good presentation.
Thank you po,
If
Doc.
not, we continue with the next one. Effie.
Yes po. April po, Doc.
Effie. What's your topic?
Adenomyosis po,
All
Doc.
right, go ahead.
Okay. Okay, good afternoon, doctors. I am PGI April de Tablan, and I will be presenting a case of CK, 41 years old, single, Roman Catholic, Filipino, consulted on April 19, 2021, with the chief complaint of prolonged vaginal bleeding. The history of present illness: the patient consulted at Casa Medica for UTI and was managed. On the follow-up, on abdominal palpation, a hard mass was palpated. So therefore, the transvaginal ultrasound was requested, but unfortunately, it wasn't on hand. But the patient recalled the results, and the results showed four myomas with unrecalled sizes found inside and outside the uterus. So the patient is a candidate for hysterectomy. However, she was lost to follow up due to pandemic. And at that time, there was no other associated symptoms, no vaginal bleeding, abdominal enlargement, or bowel or urinary changes. And then 1 month prior to admission, the patient experienced a prolonged menstrual bleeding, but with same amount of 45 moderately soaked pads per day, but it lasted for 10 days. It was associated with pelvic fullness, hence consult with the attending physician. And then the transvaginal ultrasound was requested, and the results showed the uterus is 7.12 by 8.87 by 8.77 with 4 myomas noted, M1 intramural subserous component right lateral 6.32 and 5.63 by 5.99, M2 intramural middle posterior 2.25 by 2.08 by 2.30, M3 intramural fundal 2.53 by 2.11 by 2.83, and M4 intramural subserous upper posterior 2.30 by 3.60 by 3.58. The endometrium 0.22, cervix is 2.45 by 2.7 by 3.73. So the impression is asymmetrically normal sized anteverted uterus with myomas as described, and then thin intact endometrium, normal ovaries. So she was advised to have a total abdominal hysterectomy with bilateral salpingectomy. So the plan is, on follow-up, the plan is to do a surgery, a total abdominal hysterectomy with bilateral salpingectomy. Why? Because the patient is not desirous of pregnancy with her age. She was a 41-year-old woman. She has no partner, and initially she was advised for myomectomy. But due to the recurrence, after 2 to 3 years, she decided to have the total abdominal hysterectomy with bilateral salpingectomy. And then the patient underwent clearance, hence admission. So for the physical examination, the blood pressure is 110/80, heart rate of 84, respiratory rate of 21, temperature of 36.3, height of 5'5", weight of 61 kilograms with normal BMI of 22.4. No pallor with pink palpebral conjunctivae, but the abdomen is flabby, soft, non-tender, with mass at the hypogastric area, more on the left, approximately 6 by 4 centimeter, with regular borders, movable and non-tender, with unremarkable chest and spine and extremity. With a speculum examination, cervix is pink, smooth with no discharge. Internal examination, cervix was firm, closed. Uterus is asymmetrically enlarged to 14 to 16 week size. There is no cervical motion tenderness, no adnexal mass palpated. Rectovaginal examination with good sphincteric tone, smooth with pliable parametria. Past medical history is unremarkable with no comorbidities or previous surgeries and known allergies. Family history, the patient has diabetes mellitus and hypertension both on the maternal and paternal side. Personal history, the patient is single. She is non-smoker, non-alcohol beverage drinker. She works as a call center agent and had her first sexual contact at age 23 with one partner. So obstetric history, menarche at 13 years old with regular interval, 4 days duration, and amount of 4 to 5 moderately soaked pads per day with occasional dysmenorrhea with no medication taken. There is no history of oral contraceptive use. Pap smear was done last 2020 with negative results. LMP of first week of April and PMP of first week of March, both with unrecalled specific dates. So admitting diagnosis is CK, 41 years old, abnormal uterine bleeding, adenomyosis, multiple myoma uteri. So the plan is to have a total abdominal hysterectomy with bilateral salpingectomy. Pre-op medications were given, cefoxitin 2 grams IV loading dose. It is a surgery prophylaxis for the prevention of infection. It is a second-generation cephalosporin that inhibits bacterial wall synthesis by binding to one or more penicillin binding protein. And then bowel preparation was given, the castor oil 60 cc single dose. It is a stimulant laxative, typically causes a bowel movement to occur in 2 to 3 hours. And then the patient is on NPO. 2 units of POC RBC are available and ready for surgery. Course in the ward, for the pre-op, the patient has a normal vital signs and is awake, comfortable with no subjective complaints. No pallor with palpebral conjunctivae, clear breath sounds. The abdomen is flabby, soft, non-tender with mass at the hypogastric area, 6 by 4 centimeter with regular borders, movable and non-tender. So the pre-op IE, cervix is pulled up, firm, closed. Uterus cannot be assessed due to pelvo-abdominal mass, 6 by 6 centimeter midline, more to the left, movable with regular borders, irregular contour, with no adnexal mass. And the plan is to have total abdominal hysterectomy with bilateral salpingectomy. So for the intra-op, upon opening, the uterus is pink and smooth with myoma B, 9 by 7 by 5 centimeter, more to the left fundal area. And then the myoma A is measuring 12 by 8 by 9 centimeter at the right posterior fundal area with multiple myoma on anterior and posterior part of the uterus. And also the patient has normal bilateral fallopian tubes and ovaries. So the plan, the patient intraoperatively was transfused with 1 unit of packed RBC. So for post-op, the patient has a normal vital signs and is awake, comfortable with no subjective complaints. There is no flatus yet, no pallor with pink palpebral conjunctivae and clear breath sounds. The abdomen is soft, non-tender with dry intact dressing and with normal active bowel sounds. The urine output measuring is 560 cc in with 1 episode of inadequate urine output. Then the plan is to increase oral fluid intake and then continue the cefoxitin 1 gram IV for every 12 hours for 3 doses. And repeat CBC and retain the intrafolic catheter. So we have the differential diagnosis. We have endometriosis, leiomyoma, and pelvic inflammatory disease. First is the endometriosis. Adenomyosis and endometriosis are very similar. In adenomyosis, the cells lining the uterus grow into the uterus muscle, while in the endometriosis, the cells grow outside of the uterus, sometimes on the ovaries and fallopian tubes. So we have a picture here that's saying the adenomyosis affects the inside of the uterus, which leads to the enlargement of the uterus, while the endometriosis, the size of the uterus does not get affected with endometriosis. However, there will be adhesion. Next is the leiomyoma or uterine fibroids. These are muscular tumors that grow in the wall of the uterus. However, in the pelvic inflammatory disease, on the other hand, it is an infection of the female reproductive organs that most often occurs when sexually transmitted bacteria spread vagina to the uterus, fallopian tubes, or ovaries. So final diagnosis is CK, 41 years old, G0, abnormal uterine bleeding, adenomyosis, multiple myoma uteri, total abdominal hysterectomy with bilateral salpingectomy. So we will proceed with the discussion. So first, we're going to discuss the normal menstrual cycle. So the length of the menstrual cycle varies from woman to woman, but the average is to have periods every 28 days. The menstrual flow might occur every 21 to 35 days and last less than 8 days. So abnormal uterine bleeding. It is a bleeding in between monthly periods, prolonged bleeding, or extremely heavy period. Bleeding from the uterus that is longer than usual or that occurs in an irregular time. Bleeding may be heavier or lighter than usual and occur often or randomly. So this happens 3 to 35% of women worldwide. So when is bleeding abnormal? So bleeding or spotting between periods or after sex, heavy bleeding during your period, menstrual cycles that are longer than 38 and shorter than 24 days, irregular periods in which cycle length varies by more than 7 to 9 days or more, and bleeding after menopause. So we have the causes. We have the structural and non-structural causes of abnormal uterine bleeding. The structural causes is we have the POM, the polyp, adenomyosis, leiomyoma, and malignancy. And we have the non-structural causes, the COIN, which is the coagulopathy, ovulatory, endometrial, iatrogenic, and not otherwise classified. But I will be more focusing on adenomyosis and leiomyoma. So first is adenomyosis. Adenomyosis, again, is the inner lining of the uterus breaks through the muscle wall of the uterus. Tissue from the lining of the uterus grows into the uterine wall, enlarging the uterus. So the uterus wall thickens and may cause pain and heavy bleeding. And it usually affects older people, and it's recently been associated with infertility. So what are the symptoms? The symptoms is menorrhagia. This is the menstrual bleeding lasting for longer than 7 days. Dysmenorrhea, abdominal pressure and bloating, abnormal menstruation, pelvic pain, and dyspareunia or painful intercourse. So this one is from a journal. What is adenomyosis? Adenomyosis is an enlarged uterus caused by growth of endometrial tissue into the uterine tissue. So the risk factors here, being in 40s to 50s. Most cases of adenomyosis, which depends on estrogen, are found in women in their 40s to 50s. And adenomyosis in these women could relate to longer exposure to estrogen compared with that of younger women. So we can also include childbirth or prior uterine surgery, such as C-section, fibroid removal, or dilatation, and curettage as one of the risk factors. Complications, we have chronic anemia that may cause fatigue from heavy blood loss. So diagnosis, we have pelvic exam. So during a pelvic exam, you may notice that the uterus has gotten larger, softer, or more painful when palpated. So transvaginal ultrasound is the first line imaging technique. It uses sound waves to produce images of pelvic organs. It is inexpensive and readily available. So we have here the signs that will help us to diagnose adenomyosis in the ultrasound. We have increased myometrial echogenicity or linear hyperechoic bands, extending deep into the myometrium, hypoechoic areas in the myometrium compatible with hyperplasia of the muscle tissues surrounding the ectopic tissue, anechoic areas due to glandular dilatation or myometrial cysts, poor definition of junctional zone, and enlargement of the uterus with asymmetrical thickening of one of the walls. Next is MRI. MRI can show uterine enlargement and thickening of certain areas of the uterus, which can be indicative of adenomyosis. So it can be diffuse or focal. So we have here the most established MRI finding, the diagnostic finding, the thickening of junctional zone exceeding 12 millimeters. And we have high signal intensity myometrial foci on T2 or T1 weighted images. It is also characteristic. It is additional, but not an obligatory criterion. Next is the treatment. We have anti-inflammatory drugs to relieve mild pain or ease cramping, the NSAIDs. Hormone therapy to control heavy or painful periods, the combined estrogen-producing birth control pills, hormone-containing patches, vaginal rings, progestin-only contraception, aromatase inhibitors, and GnRH analogs. Hysterectomy. And then we have also a lifestyle and home remedies for the pain. Soak in a warm bath, use a heating pad on your abdomen, and take an over-the-counter anti-inflammatory medication. So the last topic is the leiomyoma. What is leiomyoma? Leiomyoma is a non-cancerous growth of the uterus that often appear during childbearing years. It arises from the overgrowth of smooth muscle and connective tissue in the uterus. And it ranges in size from seedlings and then undetectable by the human eye to bulky masses that can distort and enlarge the uterus. It is the most common benign gynecologic tumor. So the symptoms of leiomyoma are heavy menstrual bleeding, prolonged periods, pelvic pressure or pain, frequent urination, difficult emptying the bladder, constipation, backache or leg pain, infertility, and then risk factors, genetic changes. Many fibroids contain changes in genes that differ from those in normal uterine muscle cells. Hormones, the estrogen and progesterone, because these two hormones stimulate the development of uterine lining during each menstrual cycle in preparation for pregnancy and appears to promote growth of fibroids. Fibroids contain more estrogen and progesterone receptors than normal uterine muscle cells do. So other growth factors, substances that help the body maintain tissues such as insulin-like growth factor that may affect the fibroid growth. The extracellular matrix, it is the material that makes cells stick together and it is increased in fibroids and makes them fibrous. So reproductive age, the childbearing years, race, although any women of reproductive age can develop fibroids. Black women are more likely to have fibroids. Heredity, family history who had fibroids, sister, your mother, and then other factors. Menarche at an early age, obesity, vitamin D deficiency, having a diet higher in red meat or lower in green vegetables, and drinking alcohol. Again, for the complication, we have chronic anemia that may cause fatigue from heavy blood loss. And now we have the FIGO grading. FIGO grading is the International Federation of Gynecology and Obstetrics developed a grading system for endometrial carcinoma. It is based on the percentage of cells in the tumor that grow in sheets called the solid tumor growth. So here, it lists the main types of fibroids according to their localization. We have the intracavitary fibroid, submucosal fibroid, the less common, intramural fibroid, which is the most common, subserosal, and pedunculated fibroid. So additional information is that submucosal and intramural leiomyomas may affect fertility by inhibiting sperm transport and interfering with normal implantation. So here we have another picture. The intramural fibroids grow within the muscular uterine wall, while the subserosal fibroids project to the outside of the uterus, and then the submucosal fibroids bulge into the uterine cavity. So again, for the diagnosis, we have the pelvic exam that you may notice that the uterus has gotten larger, softer, or more painful when palpated. And then the transvaginal ultrasound. It is the first-line imaging technique because in suspected fibroids, and it shows high sensitivity and specificity in diagnosing this condition. So during ultrasound examination, leiomyoma usually appears as well-defined, solid, concentric, hypoechoic masses. This appearance results from the prevailing muscle, which is observed at histologic examination. So these solid masses absorb sound waves and therefore causes a variable amount of acoustic shadowing. Next is MRI. So the MRI has an important role in defining anatomy of the uterus and ovaries. It is also helpful in planning myomectomy or selective surgical removal of a fibroid. And then the fibroids appear as sharply marginated areas of low to intermediate signal intensity on T1 and T2 weighted MRI scans. So 1/3 of fibroids have a hyperintense rim on T2 weighted images. So as a result of dilated veins, lymphatics, or edema. Next, we have the hysterosonography. So hysterosonography is also called a saline infusion sonogram. That uses sterile saline to expand the uterine cavity, making it easier to get images of submucosal fibroids and the lining of the uterus. So in women attempting pregnancy or who have heavy menstrual bleeding. Next is the hysterosalpingography. It uses a dye to highlight the uterine cavity and fallopian tubes on X-ray images. And this is recommended if infertility is a concern. These tests can help to determine if the fallopian tubes are open or blocked and can show some submucosal fibroids. Hysteroscopy. So for this, we are inserting a small lighted telescope called hysteroscope through the cervix into the uterus, then inject saline, expanding the uterine cavity to examine the walls of the uterus and the openings of the fallopian tubes. So the treatment, we have the uterine artery embolization, MR-guided ultrasound surgery, surgical removal of tumor, hysterectomy, and medications. But we will start on medication. We have the gonadotropin-releasing hormone agonists. They treat fibroids by blocking the production of estrogen and progesterone. So putting into a temporary menopause-like state. We have leuprolide, buserelin, and triptorelin. As a result, menstruation stops, fibroids shrink, and anemia often improves. We have progestin-releasing intrauterine device. It can relieve heavy bleeding caused by fibroids. It provides symptom relief only and doesn't shrink fibroids or make them disappear. It also prevents pregnancy. Next is tranexamic acid. It is a non-hormonal medication, but it is taken to ease heavy menstrual periods, and it's taken only on heavy bleeding days. For example, Listada and cyclocapron. For others, we have oral contraceptives. It can help control menstrual bleeding but doesn't reduce fibroid size. NSAIDs, it relieves pain but doesn't reduce bleeding from fibroids. Vitamins and iron for heavy menstrual bleeding and anemia. We have MRI-guided focus ultrasound surgery. It is a newer technology, but it is a non-invasive treatment option. So for uterine fibroids that preserves the uterus, it requires no incision and is done on an outpatient basis. It is performed while inside an MRI scanner. So it is equipped with a high-energy ultrasound transducer for treatment. So the images gives us the precise location of the fibroid. So when it is targeted, the ultrasound transducer focuses sound waves into the fibroid to hit and destroy small areas of fibroid tissue. Next, we have a minimally invasive procedure, the uterine artery embolization. So small particles, the embolic agents, are injected into the arteries supplying the uterus, cutting off blood flow to fibroids, causing them to shrink and die. So this technique can be effective in shrinking fibroids and relieving the symptoms they cause. So we have the traditional surgery, the myomectomy, if there are multiple very large or very deep fibroids. However, scarring after surgery can affect future fertility. And lastly is the hysterectomy. So this surgery, the removal of the uterus remains the only proven permanent solution for uterine fibroids. It ends the ability to bear children, and it is a major surgery. So that would be all. Thank you.
Okay, for example, this patient approach you. Doc, you would operate on me. Why not remove my ovaries as well?
Mm, mm,
To rephrase my question, why was the ovaries left in this patient? Why was it not removed?
uh,
For future pregnancy, doc.
Wala na ngang mattress, you remove the everything else but
Sorry, doc. Sorry, sorry.
okay, remember the function of your ovaries and what are its non-contraceptive or non-childbearing functions. Maybe that will lead you to the answer, Effie. Effie.
yes, sir. Mm,
And there are two schools of thought with this. Your reproductive endocrinologists on one end and your gynecologic oncologists on one end. Meaning if this one met a gyne-onco leaning obstetrician may have removed the ovaries at 41 years old. But if you see reproendoli ng OB/GYN will leave the ovaries. What would be the reason?
Um, to preserve the hormonal levels po.
Okay. You preserve the hormonal levels because what are the functions of your hormones even if you have removed the ovaries, even if the patient would not be able to bear child anymore? What are the non-reproductive functions of the hormones that you are talking about? Particularly what hormone first, Ethel?
The estrogen and progesterone.
Okay. Your estrogen, what's the function of your estrogen that is not for childbearing? What systems does it benefit? Yes, you preserve the hormones, but for what? Do not bear a child anyway anymore. But what are the benefits of estrogen beyond giving us children, allowing us to bear children?
Mm, Doc, for ano po, cognitive health din po or bone health and other or also in cardiovascular system po.
All right. You have mentioned two. You have mentioned your cardiovascular health. That's one. Such that when we are still in the pregnant, there is still a possibility that we get pregnant or prior to menopause. Our cardiac system is protected because as you could go back, your cardiac changes of pregnancy puts a lot of load on our heart such that younger than 50, you will see men getting heart attack more than women. But it evens out, the prevalence and incidence of heart attack evens out after menopause. It equalizes. Okay. Your other that you have already mentioned is your bone health. Women past 50 would have a high tendency for osteoporosis, and our estrogen protects us from that, again, because of the possibility that we may bear child and our bone can support a pregnancy. Okay, the third system that's affected would be your vaginal health. Okay, your vaginal health, the elasticity of the vagina, such that the baby could go outside vaginally, is also provided by estrogen. So those are the three systems that are affected by hormones produced by the ovary. Aside from your skin elasticity, etc., that brings about a woman's perceived so-called beauty. Okay? Uh, plus the other effects such as your hot flushes, etc., etc. So, cutoff is 45. So, sometimes when it's around 42, 43, 44, what's 2 years between friends? So, some OBGYNs would opt to remove. Less that, for example, you operated on a patient, you left the ovary, and after 5 years, it becomes a cyst or it becomes a malignancy. That's why some gyne-oncos would prefer to remove the ovary width. But of course, your reproendo will say, no, the ovary still has function. In this patient, your ovary looks normal grossly. So, the decision to leave the ovaries behind. Okay? So, your adenomyosis, um, Main difference from leiomyoma grossly, it's asymmetric, but would present more or less the same. So your closest differential would be, of course, your leiomyoma. Your other diseases, a far differential, but you also have to consider it. Okay, so it's for adenomyosis, it's surgical. One of the Once you have bleeding, it's one of the indications for surgery. Or if patient is desirous of pregnancy, you advise the patient to get pregnant because it will decrease your estrogen and would retard the progression of your adenomyosis if you have your estrogen interruption. Okay, so take home, your ovaries are left, cut off is at 45 because of those reasons mentioned. All right. Other interns, do you have any questions, clarifications? But a very comprehensive report as well for adenomyosis. Sana iba-ibang topics, hopefully. Who's next?
Diana po, Doc.
Diana.
Opo.
Agandahan ng profile pic. Nahihiya naman ako sa profile pic ko. Pangalan lang.
Doc, sa picture lang yan. Pero personal pangit
Grabe.
picture. Kailan, Doc, ha? Screen share lang po.
Screen share na.
Opo.
Taray ng kilay, oh. Sige na. Wow, pre-eclampsia.
Good afternoon, Dr. Andres, and good afternoon, my co-interns. I'm PGA Diane, and I will be presenting the case of WB, 31 years old, G2P00010, single, Filipino, and was admitted in our institution on May 13, 2021, with the chief complaint of elevated BP. For the past medical history, the patient has no known comorbidities except for a previous hospitalization for completion curettage last 2019 in UniHealth Parañaque. For the family history, the patient's paternal side has history of hypertension and diabetes mellitus. For personal and social history, the patient is a BPO agent who cohabits with coworker who is also a BPO agent for 5 months. The patient is a non-smoker, non-alcoholic beverage drinker, and no history of illicit drug use. For the menstrual history, patient had menarche at 14 years old with regular intervals with a duration of 3 days. Uh, the patient consumes 4 to 5 moderately soaked pads per day, and with dysmenorrhea, but no medications were taken. For the gynecologic history, the patient had her first coitus at 16 years old with 4 sexual partners with no postcoital bleeding, leukorrhea, dyspareunia. The patient has a history of contraceptive use last 2019 for 6 months, no infections, and pap smear was not done before. For the OB history, um, G1 year 2019, 8 weeks OAG, incomplete abortion, and G2 for her present pregnancy. For the history of present illness, the patient was amenorrheic for 4 weeks, and pregnancy test was done which yield positive result. The patient consulted AP, and at 6 weeks, CBC urinalysis was done, and urinalysis reveals pus cells of 45 to 50. Cefuroxime 500 milligrams BID were given for 7 days, and then at 9 weeks age of gestation, urinalysis was done, which revealed uh, pus cells. So the AP gave the patient coamoxiclav 625 milligrams BID for 7 days. On her second trimester, urine CS was done and 75 grams OGTT was done, and which yields normal results. The patient was noted with BP elevation of 150 to over 100, and patient was advised for BP monitoring, BID, and was advised to take methyl dopa 50 milligrams TID.
Are you
On
methyl dopa dosage?
I mean, doc,
Are you sure with your methyl dopa dosage?
bakit yun yung na-note ko, 50.
Hmm. What is the preparation for methyl dopa if you know? I think that is 250 milligrams.
Sorry, doc.
Sige, go ahead. Proceed. Diana,
Doc.
go ahead.
1 day prior to admission, at 32 weeks age of gestation, the patient complains of elevated BP associated with headache during of vision and vomiting, 5 episodes of vomiting. The patient consulted ER and was given hydralazine 4 doses and magnesium sulfate 4 grams IV. And the patient was advised to go home and come back once with RT-PCR result.
What was the, yeah, okay. This one, it was at 32 weeks.
Apo, Doc, 32 weeks po.
Okay.
Apo. Few hours prior to admission, the patient noted BP of 170 over 100 and complaints of night pain. The patient consulted the ER, and the patient was advised to take methyl dopa 300 milligrams and BP monitoring for 30 minutes. The patient was given hydralazine 5 milligrams until fourth dose and magnesium sulfate. However, the BP still remained elevated, hence advised admission by the AP. For the review of systems, unremarkable. For the physical examination, upon arrival at the ER, the patient's BP was 180 over 120, pulse rate of 80, respiratory rate of 20, temperature of 36. Abdomen globular, and examination of the abdomen reveals a fundic height of 30 centimeters, FHT 150 is estimated fetal weight of 2,200 to 2,400 grams. Speculum examination, internal examination was not done. For the admitting diagnosis, G2P00010, pregnancy uterine 32 weeks, AOG, breech not in labor, preeclampsia with severe features, GDM. So for the discussion, the World Health Organization systematically reviews maternal mortality worldwide, and in developed countries, 16% of maternal deaths were reported to be due to hypertensive disorders. This proportion is greater than three other leading causes that includes hemorrhage, abortion, and sepsis. The working group of the National High Blood Pressure Program devised a way of classifying the hypertensive disorders during pregnancy. The basic classification was retained as it describes four types of hypertensive disease. First is the gestational hypertension. The evidence for the preeclampsia syndrome does not develop, and hypertension resolves by 12 weeks postpartum. Next is preeclampsia and eclampsia syndrome. chronic hypertension of any etiology, and preeclampsia superimposed on chronic hypertension. Importantly, this classification differentiates the preeclampsia syndrome from other hypertensive disorders because it is potentially more ominous. This concept aids in interpretation of studies that address the etiology, pathogenesis, and clinical management of pregnancy-related hypertensive disorders. So, the indicators of severity of gestational hypertensive disorders are some symptoms are considered to be ominous, such as headaches, visual disturbances, can be premonitory symptoms of eclampsia. Epigastric or right upper quadrant pain frequently accompanies hepatocellular necrosis, ischemia, and edema that ostensibly stretches the Gleason capsule. This characteristic of pain is frequently accompanied by elevated serum hepatic transaminase levels. Finally, thrombocytopenia is also characteristic of worsening preeclampsia as it signifies platelet activation and aggregation as well as microangiopathic hemolysis. Other factors indicative of severe preeclampsia includes renal or cardiac involvement and obvious fetal growth restriction, which also attests to its duration. For the incidence and risk factors, primiparity 3% versus 1.7% of secundis. Immunologic factors, tolerance through T helper 2 reaction bringing about failure of trophoblast invasion, gestational age at delivery of first pregnancy, previous pregnancy complicated by chronic hypertension, pre of 75%, pre-eclampsia 50%, eclampsia 22%, and HELP syndrome 43%. Family history of preeclampsia 2.3 times with sisterhood preeclampsia, and BMI of 4.3% among BMI of less than 19.8 kilogram per meter square, and 30.3 in those with BMI of greater than 35 kilogram. The socioeconomic status has no effect, and smoking and preeclampsia has decreased risk in patients with smoking and placental-previa. For the etiology, first is the placental implantation with abnormal trophoblastic invasion of uterine vessels. Endovascular trophoblast replace the vascular endothelial and muscular linings to enlarge the vessel diameter. The veins are invaded only superficially. In some cases of preeclampsia, however, there may be incomplete trophoblastic invasion. And with this, the decidual vessels but not myometrial vessels become lined with endovascular trophoblast. The deeper myometrial arterioles do not lose their endothelial lining and musculoelastic tissue, and their mean external diameter is only half that of corresponding vessels in normal placentas. Early preeclamptic changes include endothelial damage, incidation of plasma constituents into vessels, proliferation of myointimal cells, and medial necrosis. Lipid accumulation first in myointimal cells and then within the macrophage. The abnormally narrow spiral arteriolar lumen likely impairs placental blood flow. There are evidences that shows that the decreased soluble anti-angiogenic growth factors may be involved in faulty endovascular remodeling, diminished perfusion, and hypoxemic environment, eventually lead to release of placental debris and microparticles that indicate a systemic inflammatory response. Next is the immunological maladaptive tolerance between maternal, paternal, and fetal tissues. The histological changes at the maternal placental interface are suggestive of acute graft rejection. Some of the factors possibly associated with dysregulation include immunization from a previous pregnancy, some inherited HLA and natural killer receptor haplotypes, and possibly shared susceptibility genes with diabetes and hypertension. The extravilus trophoblast early in pregnancy express reduced amounts of immunosuppressive non-classic HLA-G, which is associated with high levels of placental oxidative products. And these changes may contribute to defective placental vascularization in stage 1 of the preeclampsia syndrome. In normal pregnancy, T helper lymphocytes are produced so that type 2 activity is increased in relations to type 1, termed type 2 bias. T helper 2 cells promote humoral immunity, whereas T helper 1 cells stimulate inflammatory cytokine secretion. Beginning in the early second trimester in women who develop preeclampsia, Th1 action is increased and T helper 1 and T helper 2 ratio changes. Contributors and enhanced immunologically mediated inflammatory reaction are stimulated by placental microparticles and by adipocytes. Next factor is the maternal maladaptation to cardiovascular or inflammatory changes of normal pregnancy. And lastly, genetic factors including inherited predisposing genes and epigenetic influences. For the pathogenesis, first, there is vasospasm of spiral arteries. Based on the direct observation of the small blood vessels in the nail beds, ocular fundi, and bulbar conjunctivae, it was also surmised for histological changes seen in various affected organs. Endothelial activation causes vascular constriction with increased resistance and subsequent hypertension. At the same time, endothelial cell damage causes interstitial leakage, through which blood constituents, including platelets and fibrinogen, are deposited subendothelially. The much larger venous circuit is similarly involved and with diminished blood flow because of maldistribution. Ischemia of the surrounding tissues can lead to necrosis, hemorrhage, and other end organ disturbances characteristic of syndrome. One important clinical correlate is marked and attenuated blood volume seen in women with severe preeclampsia. Next, for endothelial cell activation, protein factors, likely placental, are secreted into the maternal circulation and promote activation and dysfunction of the vascular endothelium. The circulating endothelial cell levels are elevated fourfold in the peripheral blood of the preeclamptic women. Intact endothelium has anticoagulant properties, and endothelial cells blunt the response of vascular smooth muscle to agonists by releasing nitric oxide. Damaged or activated endothelial cells may produce less nitric oxide and secrete substances that promote coagulation and increase sensitivity to vasopressors. Further evidence of endothelial activation includes characteristic changes in glomerular capillary endothelial morphology, increased capillary permeability, and elevated blood concentration of substances associated with endothelial activation. So, these are some methods to prevent preeclampsia that have been evaluated in randomized trials. First is the dietary manipulation, low salt diet, calcium or fish oil supplementation, exercise, cardiovascular drugs such as diuretics, antihypertensives, antioxidants such as vitamin C and vitamin E and vitamin D, and antithrombotic drugs such as low-dose aspirin, aspirin dipyridamole, aspirin plus heparin, and aspirin plus ketanserin. For the management of preeclampsia, wait lang. uh, for the control of hypertension, anti-hypertensive treatment should be started in a woman with BP of 160 over 110 or at lower degrees of hypertension in the presence of potentially severe disease. The ABP to be at 140 to 155 systolic and 90 to 105 diastolic, or mean arterial pressure of 90. Methyl dopa 0.5 to 3 grams in two divided doses. Labetalol 200 to 1,200 milligrams in 2 to 3 divided doses. Nifedipine of 30 to 120 milligrams of a slow-release preparation. Hydralazine of 50 to 300 milligrams in 2 to 4 divided doses. And beta receptor blockers 50 to 200 milligrams into 2-4 divided doses. And corticosteroids for lung maturity, given it is given between 24 to 34 weeks age of gestation to enhance lung maturity. The recommended dose for betamethasone is 12 milligrams for 24 hours for 2 doses, and dexamethasone 6 milligrams every 12 hours for 4 doses. And lastly, is to prevent convulsion. So magnesium sulfate is the drug of choice, given as loading dose of 4 grams low IV over 5 to 10 minutes, and 10 grams deep intermuscular, 5 grams to each buttock, then 5 grams IM every 4 hours until 24 hours postpartum. And loading dose of 4 grams IV followed by IV infusion of 2 grams per hour. Incorporate at 20 grams magnesium sulfate of for 10 ml ampules of 50% magnesium sulfate to 1 liter D5 water or NM, and infuse IV at a rate of 100 ml per hour. Reduce the drip to 1 gram per hour after 24 hours. And counseling for future pregnancy, for subsequent preterm birth, placental abruption, fetal growth restriction, and hypertension in future pregnancies. That would be all po. Thank you.
How will you relate it to your patient? What happened to your patient? Pinauwi.
Hello, Doc.
What happened to your patient? Was sent home?
Opo, Doc. Pinauwi po siya nung first na nagkaroon ng symptoms such as headache, Doc, tapos blurring of vision and vomiting. Kasi daw wala pa pong swab na resulta. Tapos pinabalik po siya once na may swab na resulta. Pero yun yung day before admission, Doc. And then yung the day of admission, few hours after dinner po, biglang sumakit po yung batok ng patient. Then yung BP po ng patient, 170/100 po. And then tumawag po sa AP. Tapos binigyan po ng methyl dopa sa ER, 300 milligrams, Doc. And then, ayun po, inadmit na po kasi po hindi po bumababa yung BP, Doc.
And then, what happened?
Doc, kinabukasan, Doc, na CS yung patient.
At how many weeks?
32 weeks, Doc.
32 weeks.
Apo.
If you were the attending physician, would you have sent the patient home?
Doc, hindi
First
po.
time. What would you have done?
Doc, if I were the EP po, ibibigay ko po lahat ng pwedeng medications po to lower the BP po. And then kung wala po talagang, hindi po talaga bumababa, Doc, termination of pregnancy, Doc.
Okay, what are your hypertensive armamentarium? You are at methyl dopa. How many tablets were given? 2 tablets?
Opo, Doc. 2 tabs po. In-increase po yung methyl dopa niya from 1 tab. Ginawa pong 2 tabs po. TID.
What is your maximum dose, as you have mentioned in your report?
300, Doc.
Is it 300? Parang mali yan. Hindi yan 300. Yung binigay. Nasa last slides mo. What's the maximum dose of your methyl dopa?
Doc, 0.5 to 3 grams.
3 grams. Your 3 grams would be equivalent to 3,000 milligrams. Correct?
3,000. Yes po.
So if your maximum dose is 3,000 milligrams, how many tablets per day could you give in 2 to 3 divided doses? Your formulation is 250 milligrams per tablet.
$1,000 Doc every
So you could give as high as 4 tablets 3
4
times a
tablets.
day to consider it maximum dose.
Apo Doc.
Okay, so oral medications available in the Philippines you have not maximized yet. Okay?
Apo Doc.
Second, what is your IV hypertensive of choice? What was used on the patient?
Magnesium sulfate.
Kasi sabi mo lang ang magnesium sulfate is to
Hydralazine.
caution.
Doc, nalilito na ako.
Yung isa-isa pa natin eh. Ako na nagsabi ng sagot tuloy. Nasabi ko, what's your IV hypertension? It's your hydralazine.
Hydralazine,
Your
Doc.
hydralazine.
Doc, hydralazine 5 milligrams IV.
Maximum dose?
300 milligrams po.
Okay.
300 milligrams in 2 to 4 divided doses po.
Yes, usually you reach up to 3 doses every 15 minutes, 5 to 10 milligrams per IV push. If still that doesn't work, what do
Opo,
you
Doc.
Hindi pa rin, di ba? Mataas pa rin ang BP. If still,
Opo, Doc.
if still your IV hydralazine does not work, what could you give? Before you could say that this patient has uncontrolled hypertension, irretractable with medications, etc., etc.
Nifedipine.
IV na tayo, babalik ka sa oral. O sa IM, anong binibigay na drip? What does medicine give?
Nicard.
Card. You give me cardipine, 1 amp in a 1 liter solution, depending on the rate So before you even reach this decision of uncontrolled hypertension, you have to maximize all your hypertensive medications.
Opo, Doc.
What could be the other reasons why this patient eventually underwent a cesarean? Aside from your hypertension, what are the labs that you should request for that may help you in assessing the severity of your preeclampsia syndrome? What syndrome is that?
Help po, Doc.
Okay, what is HELP syndrome and what are the laboratory parameters of HELP?
HELP syndrome po is a complication of hypertensive disorders in pregnancy, indication for CS. The component of HELP po is hemolysis, elevated liver enzymes, and low platelet count.
Okay, so your parameters would be your liver enzymes, your AST, ALT,
And platelet count po, Doc. LDH, Doc, greater than 600. AST, ALT, 2 times elevated. And then platelet count less than 100,000.
Okay, so it will depend. We often use your Mississippi criteria more than your Tennessee. That would assess the severity of your preeclampsia and will aid you if you will terminate or not. Okay. What else will help you decide in deciding if the patient is for terminate would benefit more with termination of pregnancy or we could prolong a little bit more? So, meron na tayong clinical, meron na tayong laboratory. What's next? How will your imaging help you? How would you monitor this pregnancy?
Ano, Doc? CT, Doc, and MRI?
How will your CT and MRI help you?
Ano po, Doc? Para po ano natin if yung patient makita yung cerebral edema and infarction po, tsaka hemorrhage po, intracranial.
Cranium nino ng patient nung baby.
Ano po, Doc?
Kaninong hemorrhage? Sa mother? Sa baby? If you would look at the baby, what is the best imaging modality? How would you know that there is still adequate blood flow from the mother to the baby? What kind of ultrasound will you do?
Doppler, Doc.
Doppler. Okay, what are the parameters that you will look for in your Doppler? That will signify that you have to terminate this pregnancy. What will you look for in the Doppler velocimetry?
The movement, Doc.
O movement lang, edi ano, biophysical profile lang, tone, etc., etc. What would your Doppler give you? What information? Do you remember your diastolic flow? Does it ring a bell? It could be absent or it could be reversed. What is more ominous, meaning more a greater indication for you to terminate pregnancy? Is it absent or reversed?
Doc, wala lang pwede.
Okay, Nick, I hope your educated guess is correct.
Reverse, Doc?
Reversed. Why?
Doc, reverse lang alam ko.
Ano? Hula lang.
Doc, hindi ko na alam.
Okay, sige. And more or less, reversed is like your hymenderization. So it means your blood flow is not just absent, but it has shunted from left to right. So of course, your baby's blood going into your mother is not supposed to be the case. Thereby, you have to terminate with a reverse diastolic flow. Okay. So had we seen that patient at the ER before she was sent home due to RT-PCR, again, that's another problem. What? But what would happen? We should have made sure that one, your hypertension was adequately controlled. Second, you perform your laboratory to see if you have your developing health syndrome. Third, you look at your Doppler studies to see if there is need for for termination there and then. Okay. Again, there's a lot of delay in treatment, especially in preterm problematic pregnancies because of your COVID pandemic. Most of the hospitals will not admit patients without an RT-PCR or an antigen at least. But as we know it, our obstetric patients need emergency care right there and now, and that there lies the problem. So you have to anticipate these things. Plus, there's poor prenatal care, understandably so. Okay. So we have to prevent the things that we have to prevent such that cases like this would be avoided. Delivering a baby at 32 weeks, especially in this pandemic, is very expensive. Okay. I would have had increased even at the initial BP, even at the early stages, what was already at 150, correct, Diana?
Opo, Doc.
I would have started her with at least 2 tablets 3 times a day. Okay? If the BP is controlled, I would bring it back to 1 tablet 3 times a day. That is my minimum dose. And when the patient reaches 28 weeks where your cardiac pressure is really expected to increase, your 28 weeks and above, I would not hesitate to increase it to 3 to 4 tablets per day. I have already asked the makers of methyl-dopa, why only 250? Your patient will really get anxious. How many times have I prescribed 4 tablets 3 times a day and my patient will tell me, Doktora, ang dami kong iniinom. Okay lang ba talaga to? The manufacturer says the dosage is 250 primarily because of cost. Okay? Your 250 milligram tablet is 20 pesos per tablet. So imagine 12 tablet regimen, it's a 240 pesos regimen per day. But compare that with the cost of delivering preterm, delivering hypertensive, etc., aside from the safety of the baby, 240 is nothing. Okay, 1. Second, what was that? Your laboratory parameters you establish from the baseline such that when you encounter problems, okay, you could repeat your labs and see if there is any proteinuria, etc., etc. All right. And thirdly, your Doppler. So you have, ideally, it's every 2 weeks Doppler, but again, it's expensive. So what I do, I alternate it with your biophysical, then your Doppler. Okay? I have one last.
Doc, thank you po. Ay, hindi pa pala tapos.
Meron ka pa ba?
Hindi po, Doc. Akala ko po may ano po kayo.
Kalimutan ko tuloy yung last ko. What was my last? Wala, nakalimutan ko na. Nawala na sa nabura na. Okay. Anyways, so your hypertensive patients need our utmost care. Okay? Your magnesium sulfate, that's correct. There's no more, is there still room for the alternate buttocks? Some, if they could not monitor or there's no infusion set, some hospitals still give it by buttocks, but your drip 2 milligrams per hour dissolved in your D5 water is the one that's recommended. Okay. Last, what's your therapeutic level for magnesium? And what will you look out for as complications of magnesium overdose? What could happen?
Dok, yung therapeutic level po ng magnesium, if 4 grams IV po, 2 grams per hour in 24 hours.
I mean therapeutic level. What's the therapeutic window of your magnesium? Such that if you measure it in your patient, it has to be in this window. Because more than this, it would cause your magnesium overdose symptoms. Or you could answer the side effects more. What will you look out for when you give your magnesium sulfate?
Absent po ng deep tendon reflex.
Okay, absence of your DTRs. What else? Excuse me.
Renal insufficiency, Dok.
Sorry. Okay, what was your second answer?
Respiratory depression, Dok.
Okay, respiratory depression. Okay, your deep tendon reflexes, and what's the third one? Sabi mo na kanina eh. Renal.
Renal insufficiency.
Output is affected. Okay, so what's the first to go away? Your DTR, then your urine output, then so you will see a table in Williams stating that at this level, DTRs will go away, etc. And lastly, depending on your magnesium level. Alright? Complicated topic. There's a lot to be discussed when you discuss preeclampsia, and we haven't even touched on the possibility of abruptio, etc., etc. But your preeclampsia is managed quite per patient, and has a lot of nuances in your management. Again, if you have a hypertensive patient at the ER, never perform an internal examination for fear of pushing patient to eclampsia. Okay? So bring down the BP first before you even attempt to do a speculum or an internal examination. All right? Okay,
Thank you,
let's
Doc.
next.
Will share screen na po, Doc.
Sige, Giselle.
Visible na po ba yung slides?
Go ahead.
Good afternoon, doctors. I'm postgraduate Giselle Jane Ignacio, and today I'll be presenting to you a case of TV, 28-year-old, B1P0, 40 weeks and 2 days age of gestation with a chief complaint of hypogastric tone, admitted last May 2021. For the past medical history and family history, it was both unremarkable. Under personal and social history, the patient is a non-smoker, non-alcoholic beverage drinker, also denies use of illicit drugs. The patient is currently employed as an administrative assistant and is cohabiting with a 34-year-old career for 4 years. For the menstrual history, the patient had her menarche at 11 years old with regular interval lasting for 3 to 5 days using 4 fully soaked pads and no associated symptoms. For gynecological history, there is no history of oral contraceptive use, and pap smear done was last 2019 with normal results. For sexual history, the patient had her coitus at 20 years old with two non-concurrent sexual partners and no history of dyspareunia and or postcoital bleeding. For the obstetric history, the patient is a baby gravida with the previous menstrual period of June 20, 2020, with the last menstrual period of July 25, 2020, and age of gestation completed at admission was at 40 weeks and 2 days, and then estimated date of delivery was May 1, 2021. So for the history of present pregnancy, the patient was amenorrheic for 6 weeks and had a PT which revealed positive result. Patient then sought consult at Olivares Hospital where transvaginal ultrasound was done which revealed 6 weeks AOG. Patient was then started on prenatal vitamins and had 4 unremarkable prenatal checkups at the said hospital. Meanwhile, at 26 weeks AOG, patient sought first consult at Janelta OPD where 75 grams OGTT was done and which revealed normal results. Patient had unremarkable checkups until 37 weeks AOG. The patient was diagnosed with mixed vaginal infection and was treated with metronidazole plus miconazole suppository at bedtime for 7 days. Meanwhile, at 39 weeks AOG, BPS was done, noted with turbidities. At that time, the consideration of the AP was vernix caseosa versus meconium stain. Patient was then advised to undergo NST, which revealed reactive results. Patient was then started on evening primrose capsule, 3 capsules Q6, and internal examination at that time was 3 centimeters dilated. Few hours prior to admission, the patient consulted at the ER with chief complaint of occasional hypogastric pain. NST was done, which revealed reactive results. Internal examination at this time was still 3 cms dilated. Patient was then sent home. Afterwards, the patient came back at the ER still with hypogastric pain. Upon admission, the physical examination was that the patient was awake, conscious, and coherent, not in cardiorespiratory distress, with normal vital signs. The skin was warm to touch with good skin turgor, no pallor, pink fever conjunctiva, and anonycleric sclerae, and chest and lungs revealed symmetric chest expansion, clear breath sounds, no retractions, and cracks. For the cardiovascular system, a dynamic precordium, normal rate, regular rhythm was observed. On abdominal examination, the abdomen was globular with linea nigra. Lupul's maneuver 1 revealed doughy, slight irregular mass. Lupul's maneuver 2, wide convex structure, smooth surface with on the right and irregular nodularities on the left. Lupul's maneuver 3 revealed hard round mass, slightly ballotable. While Lupul's maneuver 4, the examiner's fingers almost touching each other, with the fundic height of 30 centimeters and a fetal heart tones of 140s on the right lower quadrant. Contractions at this time were every 3 minutes, moderate, lasting for 50 to 60 seconds. IE at this time in the ER was 6 centimeters dilated, 70% effaced, intact bag of water, cephalic station -3. On the speculative examination, the cervix was pink, smooth, with minimal mucoid discharge, and for the extremities, full equal pulses with no edema. With that, the admitting diagnosis is G1P0, pregnancy uterine, 40 weeks and 2 days, age of gestation, cephalic in labor. So for the plan upon admission was for spontaneous vaginal delivery. So upon admission, the patient was at the 6th hour of labor, i.e. at the ER was at 6 centimeters dilated, 70% effaced, intact bag of water, and cephalic, station -3. At the 7th hour of labor, the patient was given epidural anesthesia upon request. IE at that time was 7 centimeters dilated, 70% effaced, but there was now spontaneous rupture of bag of water with clear amniotic fluid, still at station -3. On the 8th hour of labor, contractions were every 3 to 5 minutes, moderate to strong, lasting for 50 to 60 seconds. IE at that time was 8 centimeters dilated, 70% effaced, rupture bag of water, cephalic, now at station 0. On the 9th hour of labor, contractions were 3 to 4 minutes apart, strong, lasting for 50 to 60 seconds. Oxytocin was then started at 8 drops per minute. IE at that time was at 9 centimeters dilated, 80% effaced, rupture bag of water still at station 0. Afterwards, oxytocin was titrated to 12 drops per minute. On the 11th hour of labor, oxytocin was still at 12 drops per minute, with contractions every 3 minutes, strong, lasting for 40 to 50 seconds. IE at that time was 9 centimeters dilated, almost fully effaced, rupture bag of water, cephalic, station +1. On the 12th hour of labor, oxytocin was at 12 drops of oxytocin was at still 12 drops per minute, with contractions every 3 minutes, strong, lasting for 40 to 60 seconds. IE at that time was that patient was 10 centimeters dilated, fully effaced, with rupture bag of water, cephalic, station +1. On the 13th and 14th hour of labor, IE was still at 10 centimeters dilated, fully effaced, with rupture bag of water, cephalic, station +1. A clinical pelvimetry was done, which revealed bilateral ischial spines, bilateral ischial spines were prominent with convergent side walls and shallow sacral curvature and a suprapubic angle less than 90 degrees. So our patient then underwent primary low transverse cesarean section for arrest and descent secondary to midplane and outlet contraction. Preoperative IE was that the patient was fully dilated, fully effaced, ruptured bag of water, cephalic, station +1. Intraoperative findings is that there is a thinly stained amniotic fluid head in right occiput posterior with placenta fundally located with an estimated blood loss of 600 cc. And the outcome was a life-term baby girl with a birth weight of 3,005 grams and an Apgar score of 99 and a Barrett score of 40 weeks, appropriate for gestational age.
Was
So the
there
course, yes po, Doc.
was there kaput?
Yes po, Doc. 2 cm kaput po, more prominent on the right po.
Where?
On the occipitoparietal area po, Doc.
Parietal. So what does that mean? Will you discuss that?
Doc, yung meaning po ng kaput is that there was already a resistance po while the fetal presenting part was at the station +1 po. It may be due po to the when it comes to the IE po and also the prominent ischial spines of the maternal pelvis po, Doc.
If there's kaput, what does it mean? What does it tell you?
When there's a kaput po, Doc, it means that there's an inflammation po of the edema po of the fetal presenting part po.
What will produce your edema? Bakit siya namaga?
Doc, may trauma po or may pressing ano po, pressure po dun sa presenting part po.
Okay, what produced your pressure on the presenting part?
Ano po ulit, Doc? Sorry po.
3,000 lang yung baby mo, hindi lumabas?
Opo, Doc.
What could be a possible reason? I'm emphasizing this because in dystocia, especially if you plan to go into obstetrics, it's one of the hardest reasons to defend as far as why you performed a cesarean section. Okay? So, if you plan to show a dystocia and a partogram curve, you must be sure on what really happened, on why the baby did not come out. Okay. I am asking if there is kaput because that may point to the very reason why this patient had to undergo a cesarean section. So what will your kaput tell you? A parietal kaput at that. And you are saying that it is right occiput posterior. So what could have happened with this patient?
Doc, it is possible po, Doc, na the fetal presenting part po did not undergo internal rotation.
Thereby producing what? Pag may bukol siya sa parietal area, anong pwedeng posisyon ni baby? Could you imagine? Sabi mo na maga. And what concepts in obstetric would point to that occurrence? What could have happened? Your head is what? What happened to your head, your fetal head?
Doc, it's possible po that the fetal head was trapped po due to the cephalopelvic disproportion po.
Cephalopelvic disproportion. Hindi, it did not go straight. Oh, ayun na, no? Halos bigay ko na sagot. May parietal, edema, may kaput, right occiput posterior. So where does it point? If it's right occiput posterior, what am I driving at? Tapos, cephalopelvic disproportion, saan siya bumunggo? That would have produced that kaput. Dalawa lang naman yan kung palabas, either sa taas o sa baba. Anong bubungguan sa taas?
Doc, sa taas po, possible po na yung symphysis po.
Okay. On the other end,
yung coccyx po, Doc.
okay. And what would that coccyx or your promontory, what phenomenon is that? If it points towards the symphysis pubis or it points towards your coccyx or your promontory?
Asyncretism po, Doc.
Okay. So, what is asyncretism? So, there's two, anterior and posterior. In your case, is it anterior or posterior? Or nakakalito kasi talaga siya. So, lagi siyang baliktad, guys. Okay? If you're thinking anterior, it is not your pointing to your symphysis pubis. Think the other way. If it's posterior, think symphysis pubis, even if in actuality, you think that it's the anterior, because the basis of your anterior or your posterior syncretism would be your caput, depending on your position. Sige, go ahead. Proceed with your report. Most likely, this had a syncretism, kaya hindi siya lumabas.
For the course in the ward, on the first hospital day, the patient had no subjective complaints. However, the patient had several episodes po of inadequate urine output. This was resolved po with fast drip of 200 cc and also by encouraging the patient to take to increase oral fluid intake. The patient also had past flatus po and with stable vital signs. So the plan at this time was to hydrate the patient via fast drip with 200 cc and advise increased oral fluid intake, and may also take soft diet, and also may remove IFC once with adequate urine and the patient is voiding freely, and patient was started on cefuroxime 500 milligrams per tab every 12 hours for 7 days. On the second hospital day, this patient still had no subjective complaint, now with adequate urine output, and was able to pass flatus and bowel movement. The diet was as tolerated and with stable vital signs. So for the plan for this patient was to continue cefuroxime 500 milligrams per tab every 12 hours for 7 days, and was started on celecoxib 200 milligrams per tab every 6 hours or as needed for pain, and follow up at Geneto OPD after 1 week and may go home. With that, our final diagnosis is G1P11001, pregnancy uterine, delivered live-term baby girl via primary low transverse cesarean section for arrest and descent secondary to mid-plane and outlet contraction with a birth weight of 305 grams, appropriate for gestational age, cephalic in presentation with an Abgar score of 99. So dystocia, there is several labor abnormalities that may interfere with the orderly progression of spontaneous delivery. Generally, they are referred as dystocia. Dystocia literally means difficult labor and is characterized by abnormally slow labor progress. It arises from four distinct abnormalities that may exist singly or combination. Commonly used expression today, such as hepatopelvic disproportion and failure to progress, are used to describe the ineffective labors. So first, explosive forces may be abnormal. For example, uterine contractions may be insufficiently strong or inappropriately coordinated to efface and dilate the cervix. There may be also inadequate voluntary maternal muscle effort during second stage of labor. Second, fetal abnormalities of presentation, position, or development may slow labor. Also, abnormalities of the maternal bony pelvis may create a contracted pelvis. And last, soft tissue abnormalities of the reproductive tract may form an obstacle to fetal descent. More simply, these abnormalities can be simplified into three categories. They include abnormalities of the three P's. First is power, or the uterine contractility and maternal explosive effort. Next is the passenger, the which is the fetus, and the passage or passageway, which is the pelvis. So first is power. Cervical dilatation and propulsion and expulsion of the fetus are brought about by contractions of the uterus. This is reinforced during the second stage by voluntary or involuntary muscular action of the abdominal wall pushing. So, such abnormalities can include uterine dysfunction. It is where uterine contractions of normal labor are characterized by a gradient of myometrial activity. These forces are greatest and longest at the fundus, considered fundal dominance, and they diminish towards the cervix. Under uterine dysfunction, it can be classified under hypotonic or hypertonic. Under hypotonic, it means that there is low basal hypertonus and uterine contractions have a normal gradient pattern or synchronous, but pressure during a contraction is insufficient to dilate the cervix. On the other hand, hypertonic is that either basal tone is elevated appreciably or the pressure gradient is distorted. Or there is complete asynchronism of the impulses originating in each cornu. Also, there's a condition called uterine tachysystole. It is a condition of excessively frequent uterine contractions during pregnancy. It is defined as more than 5 contractions in 10 minutes, average over 30 minutes. Next is the passenger. There are also abnormalities or malpresentation when it comes to the passenger, such as which may include under the fetal presentation, the fetal lie, the fetal attitude, and fetal position. Moreover, I'll be more be focusing my discussion on the passageway, which is the pelvis. Fetal pelvic dysfunction arises from the diminished pelvic capacity, excessive fetal size, or more of usually the both. Any contraction of the pelvic diameters that diminishes its capacity can create a dystocia during labor. There may be a contraction of the pelvic inlet, the mid-pelvis, or the pelvic outlet, or a generally contracted pelvis may caused by a combination of these. The first is the pelvic inlet. Boundaries of the pelvic inlet are the symphysis pubis, sacral promontory, and the linea terminalis. The pelvic inlet usually is considered to be contracted if the shortest anterior-posterior diameter is less than 10 centimeters or if the greatest transverse diameter is less than 12 centimeters. The anterior posterior diameter of the inlet is commonly approximated by the manually measuring the diagonal conjugate, which is approximately 1.5 cm greater. Therefore, inlet contraction usually is defined as a diagonal conjugate of less than 11.5 centimeters. So in our patient, the sacral upon telemetry, the sacral promontory was not observed. Hence, we can conclude that the inlet of our patient is adequate. Now let's move on to the mid-pelvis. The mid-pelvis extends from the lower margin of the symphysis pubis through the level of the ischial spines up to the tip of the sacrum. Although there is no precise manual method of measuring mid-pelvic dimensions, a suggestion of contraction sometimes can be inferred if the spines are prominent, the pelvic side walls converge, or the sacrosciatic notch is narrow. In the case of our patient, the ischial spines of the patient is prominent bilaterally, which would mean that it is contracted. The pelvic side walls were converging instead of diverging, and the sacral curvature was shallow. Hence, we can conclude that the mid pelvis of our patient is contracted. Lastly is the pelvic outlet. The pelvic outlet is bounded arterially by the pubic arch, laterally by the ischiopubic rami, ischial tuberosity, and sacrotuberous ligament, and posteriorly by the tip of the coccyx. Contracted pelvic outlet is usually defined as an interischial tuberosity diameter of 8 cm or less. With increased narrowing of the pubic arc, the occiput cannot emerge directly beneath the symphysis pubis but is forced farther down into the ischiopubic rami. When it comes to the patient, the bituberous diameter was not observed, so we can say that it was an adequate measurement. The coccyx was also not observed, so it was also adequate. However, the pubic arc was measured at less than 90 degrees. Therefore, we can conclude the outlet of our patient is also contracted. Likewise, dystocia can be brought about by abnormal labor patterns. This table is lifted from Williams. A prolongation disorder, particularly under that is prolonged latent phase. So the latent phase is 1 to 3 centimeters. It can be diagnosed with nulliparous if it's greater than 20 hours, and if it's more than 14 hours for multigravidas. The management for this is that cesarean section has no place as a method of treatment for prolonged latent phase without other clear indications like documented CPD or non-reassuring fetal status. The management is that we should avoid admission to the labor and delivery area until active labor is established. Next is protraction disorders. Active phase dilatation is 3 to 5 centimeters. So protractive active phase dilatation can be diagnosed if it occurs among nulliparous, less than 1.2 centimeters per hour, and less than 1.5 centimeters per hour under multigravidas. On the other hand, protractive descent can be diagnosed with nulliparous if it occurs less than 1 centimeter per hour and less than 2 centimeter per hour in multigravidas. I'll be more focusing on the arrest disorders. Prolonged deceleration phase is where in cervical dilatation is arrested to 8 to 9 centimeters. It can be diagnosed if it's greater than 3 hours in nulliparous and greater than 1 hour in multigravidas. In secondary arrest in dilatation, there is a progressive cervical dilatation, but it stops at the phase of maximum slope. It can be diagnosed for both nulliparous and multigravidas if it occurs greater than 2 hours. So for a patient, there was an arrest in descent. This is where a progressive descent stops during pelvic division at labor station +1. It can be diagnosed for both nulliparous and multigravidas if it occurs greater than 1 hour. On the other hand, it's failure of descent if there is no descent in deceleration phase or the second stage or at station 0. So for the management of arrest disorders is first is to rule out CPD. Cesarean section is not performed for labor arrest until there was at least 4 hours of a sustained uterine contraction pattern of greater than 200 Montevideo units or a minimum of 6 hours of oxytocin augmentation if the contraction pattern could not be achieved. So in the case of our patient, we have a patient with contracted mid-pelvis and outlet, which led to the arrest and descent, hence the surgical intervention. So it is very important that when we see patients in the labor room or when we admit patients who are in labor, we should be aware of the different parameters of dystocia, such that we should also foresee that we should diagnose them early, since there are a lot of complications for dystocia. Under maternal complications include uterine rupture, fistula formation, pelvic floor injury, and postpartum lower extremity nerve injury. On the other hand, it also has complications with the perinate of the fetus, such as sepsis, caput succedaneum, molding, and mechanical trauma. That will be all po. Thank you.
Pointed for your report, I have already mentioned your CS would have a lot of reasons, and hardest to defend one would be dystocia. Another CS indication that is hard to defend is your non-reassuring fetal status. Okay. Compared to, for example, doing a breech primi, doing a placenta previa, doing a transverse back down. So these are clear-cut indications, but not so with your dystocia and your non-reassuring fetal status, especially if you go in a training hospital where every cesarean section is uh, audited. Okay. Audited, why? Because we have such a high cesarean section rates. So according to the WHO, it's supposed to be 10 to 15% at the most. Perpetual is at 50%, 40 to 50%. Okay? Asian is at 80%. So what are the repercussions of this? Eventually, with cesarean sections done left and right, of course, placenta accreta, etc., complications will increase once you become the general practitioners or your OBGYNs. So that's why it's called normal delivery. Cesarean is an abnormal delivery, meaning something happened, something wrong happened. So, of course, logistics issue, doing a CS just takes 1 hour. Doing labor watch takes more time. Financial issue, it is more rewarding for a cesarean section financially for the OBGYN. But remember, those are not the main reasons why you went into medicine. Okay, last report. Please share your screen.
Doc, nakikita na po yung yung
Hindi
slide.
pa, hindi pa, Hana.
Wait lang po, Doctor.
Ice cookie. Ice cookie.
Hana, anong problem? Ayaw mag-share?
Yes po, hindi po nagkakashare. Sorry.
Ilan reporters next week? 4?
Or po, Doc.
Kung ayaw niya, ayan na. Sige, go ahead. Sabihin ko sana kung ayaw, next week ka na lang eh. Next ano. Sige, masaya din to, postpartum hemorrhage. I do appreciate na iba-iba ang topics natin for this afternoon. Nakakabuhay ng dugo. Sige, go ahead, Hannah.
Yes, po, Doc. Good afternoon, doctor. So I'll be reporting postpartum hemorrhage. So patient EP is a 34-year-old female who has an OB score of Gravida 4, Para 4, 4003, who is married and a Roman Catholic residing at Las Piñas City. She was admitted at April 28, 2021. So her chief complaint was persistent vaginal bleeding. So 4 hours prior to admission, the patient delivered via normal spontaneous vaginal delivery with perineal support at a nearby lying-in clinic, which was assisted by a midwife. According to her, there was no difficulty during the delivery of the baby, which only took at least 30 minutes upon arriving at the birthing clinic. On the other hand, it took more than 40 minutes before the delivery of the placenta. There was no dizziness, headache, or dyspnea noted, and according to her, she does not recall any medications given either intramuscularly or intravenously. Vaginal bleeding persisted even after the delivery of the placenta. Hence, she was advised by the midwife to seek consult at a higher center. So upon arriving at the emergency room, it was noted that her adult diaper was moderately soaked with blood clots. So for past medical history, it was unremarkable. She does not have hypertension, diabetes, cardiovascular accident, cancer, asthma, or COPD, with no past surgical procedures and no allergy to any food or drugs. So for also the family history was also unremarkable with no known heredofamilial diseases such as hypertension, diabetes, cancer or thyroid or any other diseases. So for personal and social history, she is a non-smoker, non-alcoholic drinker. She is unemployed and married for 13 years to a 40-year-old security guard. So she had her menarche at 16 years old, which with a regular interval, which lasts for 3 to 4 days, and consuming about 4 to 5 moderately soaked pads per day, and denies any symptoms during menstruation. So she had her first sexual contact at 20 years old with one sexual partner. So for obstetric history, she is Gravida 4 Para 4 4003. So the first pregnancy was on 2007, which was full-term boy with an estimated 3,500 to 4,000 grams birth weight at a lying-in clinic, which unfortunately expired 1 week after 1 week after birth due to multiple congenital anomaly. And then her second pregnancy was on 2008 with outcome of a full-term girl with also an estimated birth weight of 3,500 to 4,000, and also was also delivered at the lying-in clinic. And then her third pregnancy was at 2009, also born at full-term boy with an estimated birth weight of 3,500 to 4,000 at Josefa Bella Hospital. And then the fourth pregnancy was the previous pregnancy delivered at the lying-in clinic. It was the baby had a birth weight of 3,200 grams. So upon physical examination, the patient was conscious, coherent, oriented to time, place, person, and event, and ambulatory and not in cardiopulmonary distress. Her vital signs were as follows. So blood pressure was 90/60, and then pulse rate was 105, which is high. So she is tachycardic, and she is tachypneic with 24 circulations per minute. But according to her, she's not having difficulty breathing. And then she was a febrile with a temperature of 36.5. So the skin was pale with a palmar pallor. Head and neck was So for the head and neck, there was a symmetric hair distribution with normal hair pattern. The scalp and the hair are symmetric with no tenderness, no masses. No cervical lymphadenopathy. Trachea is of midline with no palpable thyroid gland. The eyes was also symmetric and normally aligned with palpebral conjunctiva and anecteric sclera. Pupils are equally round and reactive to light and accommodation. So for the ears, nose, mouth, and throat, it was devoid of masses or swelling and ulcerations. There was dry lips with slightly pale lips. For the chest and cardiovascular system, there is symmetric chest expansion with no adventitious breath sounds, with normal rate and regular rhythm. So upon examination of the abdomen, it was soft, non-tender abdomen with well-contracted uterus and the extremity. And as for the extremities, there was no, it was unremarkable. So for the speculum examination, it was noted to have active vaginal bleeding and blood clots, and it could not be fully visualized due to the active bleeding. And upon internal examination, the cervix is soft, open, uterus well contracted and palpated at the level of the umbilicus, with no hematoma, no cervical motion tenderness, no adnexal mass noted, and with blood clots on examining fingers. So for salient features, the patient is 34-year-old with obese score of G4P4 for Cesarean with persistent vaginal bleeding, and which started at 4 hours prior to admission, and previously delivered via normal spontaneous vaginal delivery. There was no problem with the delivery of the baby, but it took 40 minutes. It took more than 40 minutes upon the delivery of the placenta. Vaginal bleeding then persisted until admission, and it was noted that the adult diaper was moderately soaked with blood clots. So, and physical examination, the patient was had pale palpebral conjunctiva with slightly pale lips and palmar pallor, with soft non-tender abdomen and well-contracted uterus, and with upon speculum exam, there was active vaginal bleeding and blood clots, and evacuation was done usually using four fully soaked 4x4 gauze, and it could not be visualized due to active bleeding. And then on internal examination, the cervix was soft, open, and open. The uterus was well contracted and palpated at the level of umbilicus, and then there was blood clots noted at the examining finger. So for the differential diagnosis, I consider the following: genital tract laceration, a retained placental tissue, placental inversion, and uterine atony. So I consider genital tract laceration due to the precipitous delivery, wherein the patient delivered the baby 30 minutes upon arriving at the birthing clinic, and then there was no difficulty in the delivery. Also, genital tract lacerations is usually considered if there is persistent vaginal bleeding and while the uterus is contracted. And then for retained placental tissue, I consider this due to the persistent vaginal bleeding and the prolonged placental delivery, and also unknown characteristics of the delivered placenta. um, we don't know whether the placenta was complete or incomplete, which might occur in cases of a placental accreta or a placental succenturate. And then uterine inversion, due to I considered also this due to the persistence of vaginal bleeding and possible improper cord traction or excessive cord traction during the delivery of the placenta. And then I ruled this out due to the since there was no firm mass noted at the cervix, and also uterine inversion usually is associated with uterine atony. And then lastly, uterine atony is, I consider this because uterine atony is the most common cause of postpartum hemorrhage. But since the uterus was well contracted during the physical examination, I ruled this out. So the admitting diagnosis is gravida for para 4, 4003, status post non-institutional spontaneous vaginal delivery with perineal support, early postpartum hemorrhage, secondary to retained placental products versus genital tract laceration, and to consider anemia secondary to acute blood loss. So upon admission, it was noted that there was a moderately soaked adult diaper with blood clots noted. And the vital signs were as follows: blood pressure of 90/60 millimeters mercury, 105 beats per minute, and a respiratory rate of 24 circulations per minute, and a temperature of 36.5. So CBC and blood typing was done with a result of hemoglobin of 84 and the hematocrit of 28. Chest X-ray was also done and RT-PCR. So the plan was when the patient was at the emergency room, a cervical evacuation was done using four fully soaked 4x4 gauze, and then since the cervix was not fully visualized even after the evacuation, it was decided to admit the patient and to transfer her to the operating room for possible cervical vaginal wall inspection and repair, and also possible of curettage. And during the while the patient was at the emergency room, a second line IV line was also started with a D5LR and incorporated with 10 units of oxytocin. And then upon transfer to the operating room, still with noted moderate vaginal bleeding, the vital signs were as follows: 90/60 blood pressure of 90/60, pulse rate of 89 beats per minute, and a respiratory rate of 20 circulations per minute, and a temperature of 36.5. So at the operating room, a volume 500 cc was given prior to the procedure, and then manual exploration of the uterus with minimal blood clots noted, and then then they proceeded with cervical and vaginal wall inspection, wherein there was no noted lacerations on the vagina, but with 3.5 centimeters laceration noted at 8 o'clock position of the cervix. So repair of the cervical laceration was done under IV sedation, and then ceftazidime 2 grams IV was given. So after the operation, CBC 2 units of packed RBC was transfused, and then the ceftazidime was shifted to cefuroxime 500 milligrams per tab 2 times a day, and then the RT-PCR came out positive. Also, after the blood transfusion, CBC was done with a hemoglobin of 96 milligrams per deciliter and a hematocrit of 37. So upon discharge, the patient had a stable vital signs with blood pressure of 110/70, pulse rate of 80 beats per minute, and the respiratory rate of 18 circulations per minute. That she was also febrile with 36 temperature, and there was no dizziness, headache, difficulty breathing, or vaginal bleeding noted. So the discharge instructions were as follows. First, parasulfate 1 tablet, 2 grams, 2 times a day, and then mefenamic acid 500 milligrams per cup every 8 hours for 3 days for PRN for pain, and then she was to undergo quarantine for 10 more days. So the final diagnosis was gravida 4 para 4 4003, status post non-institutional spontaneous vaginal delivery with perineal support. Status post repair of cervical laceration, early postpartum hemorrhage secondary to cervical laceration with also moderate anemia secondary to acute blood loss, and a poor OB score secondary to poor OB score for early neonatal death, and then COVID confirmed, COVID-19 confirmed. So for the discussion, so postpartum hemorrhage, this definition was lifted from American College of Obstetric and Gynecologists. So it is a cumulative blood loss of more equal to or more than 1,000 or a blood loss accompanied by signs and symptoms of hypovolemia within 24 hours after the birth process, which includes an intrapartum loss regardless of route of delivery. So there are two types of postpartum hemorrhage. We have the early or the primary, which usually occurs within the first 24 hours of birth. So the common etiology for these are the following. We have the uterine atony, lacerations, retained placenta, abnormally adherent placenta or accreta, and then defects of coagulation such as disseminated intravascular coagulation and uterine inversion. So for the secondary or late postpartum hemorrhage, it usually occurs more than 24 hours after delivery and up to 12 weeks postpartum. The most common cause of this postpartum hemorrhage are the following: the subinvolution of the placental site, retained products of conception, infection, inherited coagulation defects such as factor deficiency or specifically von Willebrand. So for the etiology, we just have to remember the 4 T's. We have the tone, trauma, tissue, and thrombin. So under tone, we have uterine atony. And then for trauma, the common cause is lacerations, expanding hematoma, or uterine rupture. And then for tissue, it is retained placenta. And then for thrombin, the common cause is abruptio placenta or amniotic fluid embolism. So this is the table also listed from American College of Obstetric and Gynecologists, which shows the common etiology and the risk factors. Sorry. So for uterine atony, the most common risk factors are the following. We have prolonged use of oxytocin, high parity, chorioamnionitis, and general anesthesia. And for overdistended uterus, the most common risk is having twins or multiple gestation, polyhydramnios, or macrosomia. And then for fibroid uterus, the risk factors is having multiple uterine fibroids, while on the other hand, the uterine inversion, having excessive umbilical cord traction or short umbilical cord, and fundal implantation of the placenta puts the patient at high risk for uterine inversion. Well, for the genital tract trauma, the most common problem is episiotomy, cervical or vaginal or perineal lacerations, or uterine rupture. So the risk factors for having these problems is having operative vaginal delivery or precipitous delivery, which was also present in our patient. And then we have for the retained placental tissue. The most common problem is retained placenta or placenta accreta. And the risk factor for this is succinturate placenta, previous uterine surgery, and incomplete placental delivery. And then for abnormalities in coagulation, we have the following problems: uh, preeclampsia, inherited clotting factor deficiencies such as von Willebrand or hemophilia, severe infection, amniotic fluid embolism, excessive crystalloid replacement, therapeutic anticoagulation, and the risk factors are the following. We have abnormal bruising, PTK, fetal death, placental abruption, fever or sepsis, hemorrhage, and current thromboembolism treatment. So we go to the uterine atony. So uterine atony is a failure of the uterus to contract sufficiently after delivery and to arrest bleeding from vessels at the placental site. This is the most common cause of obstetric hemorrhage, wherein it comprises of 70 to 80% of cases of postpartum hemorrhage. And then this usually presents with soft, poorly contracted or bulgy uterus, and occasionally there are cases wherein the fundus is firm and contracted, but the lower uterine segment is dilated and atonic. So management of uterine atony, the first the bladder should be emptied, and then bimanual pelvic examination should be performed, and then manual uterine cavity exploration should be done to remove clots, rating placental fragments, and for evaluation of uterine abnormalities such as laceration or rupture. And then uterine massage can help stimulate the uterus to contract. Lastly, an additional uterogenic agents should be given to aid the contraction of the uterus. So if bleeding is still unresponsive to uterotonic agents, it is recommended to do bimanual uterine compression, wherein the posterior uterine wall is massaged by one hand on the abdomen, while the other hand is made into a fist and placed into the vagina. The fist leads the anterior uterine wall through the anterior vaginal wall, and the uterus is also compressed between the two hands. Then we proceed to the obstetric trauma. So under obstetric trauma, the most common cause is genital tract lacerations. For under genital tract lacerations, we have vulvovaginal lacerations, which takes up to 80% of women sustain some of these types of lacerations at vaginal delivery. So it is there are two types of vulvovaginal lacerations. One is superficial, which is relatively common with little to no bleeding, but may occasionally require sutures for hemostasis. And then the deep lacerations are usually accompanied by varying degrees of injury to the outer third of the vaginal vault. Sometimes these are missed unless inspection is thorough. And then we also have cervical lacerations. So for superficial, it can be seen on close examination in more than half of all vaginal deliveries. And most of these measures less than 0.5 centimeters and seldom requires repair. So for deep cervical lacerations, it is less frequent, but even these may be unnoticed. It is also more likely to be associated with a vacuum or a forceps assisted vaginal delivery, and it is not usually problematic unless they cause hemorrhage or extend to the vagina. Sorry. Then these lacerations are also divided according to the degree. So first degree is the length of cervical laceration is not over 2 centimeters. And then for the second degree, the length of laceration is more than 2 centimeters, but it does not extend to the vaginal fornices. And then the third degree is laceration. The lacerated area extends to the vaginal fornices, and it extends to, and when this extends, it is considered to be very dangerous. And then the next trauma is genital tract hematomas. This can be either labial, vaginal, broad ligament, or at the retroperitoneal. So these hematomas should be suspected in the setting of a precipitous uncontrolled delivery or an unoperated vaginal delivery. Labial, rectal, and pelvic pressure or pain or vital signs deterioration may be the only symptoms and may not be recognized until hours after delivery. This can be managed conservatively, but incision and drainage is reserved for the most severe cases, such as those hematomas that are rapidly progressive, enlarging hematomas. So exploration with suturing or packing may be needed to achieve the hemostasis. Then lastly, for the trauma, we have uterine rupture. This is a catastrophic event, and it is divided into two. Into two, we have the primary, which usually occurs in a previously intact or unscarred uterus, and then the secondary is associated with a pre-existing incision or injury or anomaly of the myometrium. So the deterioration of the maternal vital signs without obvious bleeding should alert the obstetric team that there may be intraperitoneal or retroperitoneal bleeding. So management of uterine rupture is resuscitative measures, diagnostic imaging, and surgical interventions, um, which should be done immediately. So surgical repair with specific approach tailored to reconstruct the uterus. It depends on the extent and site of the rupture and patient's current clinical condition and her desire to future childbearing. Ay, sorry. Nakaano pala. So for retained placenta, detailed visual inspection of the placenta for completeness should be conducted after all deliveries. Even if the placenta appears intact and complete, there may be additional remaining parts of the placenta, such as in cases of succintoriate lobe. So this is a picture of how to manually remove the placenta. So the left picture shows it is done by having one hand grasping the fundus while the other is inserted into the uterine cavity, and the fingers are swept from side to side as they advance. And then on the right picture, this is when the placenta has become detached and it is grasped and removed. Then for the thrombin or acute coagulopathies, when postpartum hemorrhage is associated with acute coagulopathy, this can complicate postpartum hemorrhage and can cause massive blood loss. So under thrombin, we have problems with abruption placenta and amniotic fluid embolism. So for abruption placenta, it is often associated with uterine atony, secondary to extravasation of blood, into the myometrium or covalear uterus, also disseminated intravascular, and hypofibrinogenemia. It presents as combination of vaginal bleeding, frequent uterine traction, and pain. The uterine contraction pattern is high, high frequency and low amplitude contractions. So for the amniotic fluid embolism, it is usually a rare case, unpredictable, unpreventable, and a devastating obstetric emergency. The triad for amniotic fluid embolism is hemodynamic, wherein it presents with hypotension or cardiac arrest, and then it also presents with respiratory compromise, such as hypoxia, and additionally disseminated intravascular coagulation. So these should be managed with aggressive volume replacement and initiation of massive transfusion. So how is postpartum hemorrhage prevented? So active management of the third stage of labor is the most common prevention in postpartum hemorrhage. So this is done by administering oxytocin within 1 minute after birth of the infant, and then also controlled umbilical cord traction and uterine massage after delivery of the placenta. So this is a step-by-step management of postpartum hemorrhage, which was taken from American College of Obstetric and Gynecologists. So for stage one, if stage one is done for blood when the patient has a blood loss of more than 1,000 ml after delivery with normal vital signs and lab results, and a vaginal delivery of 500 and 299 ml should be treated in stage one. So the initial steps is in inserting gauge 16 or 18 IV access, increase IV fluid such as crystalloid without oxytocin, inserting invaline catheter, and then fundal massage. So medications should be the following medication should be given: oxytocin with 10 to 40 units of per 500 to 1,000 ml solution. So oxytocin is incorporated into the IV solution. Also, another medication is methylgonovin or metragine. So this is given 0.2 milligrams IM, and this may be repeated, and it makes sure we should watch out for hypertension. So another medication is 15-methyl prostaglandin alpha, and which has a brand name of Hemabate or Carboprost. This is given 250 milligrams IM and may repeat in every 15 minutes with a maximum dose of 8 doses, and we should avoid in giving this to patients who have asthma, and use with caution when there is hypertension. Also, we can give misoprostol or cytotec with a dose of 800 to 1,000 micrograms PR, and then also 600 micrograms per RM or 800 micrograms sublingual. So we should also confirm the patient's blood type and screen for cross-matching of for 2 units of packed RBC, and then we should determine the etiology and treat. So the etiology is again the 4T, the tone, trauma, and tissue, and thrombin. And then we should prepare for the OR if clinically indicated. And then for the stage 2, if the bleeding continues, so if the bleeding is up to 1,500 ml or more than 2 uterotonics is already in use with normal vital signs and laboratory, we should proceed to stage 2. So the initial step is mobilize additional help, and then place 2 second IV line, and then draw stat labs such as CBC, coagulation, and fibrinogen, and prepare for OR. So medications, we should also consider tranexamic acid, which is given 1 grams IV over 10 minutes, and add 1 gram via vial to 100 ml and normal saline, and give over 10 minutes and may be repeated of once after 30 minutes. We should also obtain 2 units of packed RBC, and we should um, in spite of ordering the laboratories, we should not wait for the results and transfuse per clinical signs and symptoms. And then if we are considering uterine atony, consider uterine balloon or packing, possible surgical intervention, and then under possible interventions, we have the Bakri balloon, compression suture or B-link suture, and uterine artery ligation or hysterectomy, which I'll discuss later. Also, escalate therapy will with goal of hemostasis. So if blood loss, so bleeding and still continues, we should proceed to stage 3. So if continued bleeding with more than 1,500 ml of or more than 2 RBC was already given and at risk for occult bleeding, coagulopathy, or any patient with abnormal vital signs, um, we should mobilize additional help, move again the patient to the OR, and announce clinical status such as vital signs, cumulative blood loss, and etiology. So the same medications can be given from to the patient, and then again the blood bank should be informed, and then possible interventions are the same with stage 2, but there is an addition of hysterectomy. So on the fourth stage, this is already for cases who have cardiovascular collapse, such as patients with massive hemorrhage, profound hypovolemic shock, or amniotic fluid embolism. So the initial step, again, is mobilize additional resources, at ACLS, and then blood bank is informed for possible aggressive massive transfusion, and surgical interventions such as hysterectomy. So this is this just the same with the previous slides, which was from the ACOG, and this is from the FIGO recommendations of prevention and treatment with specific management lang for the different 40s of postpartum hemorrhage. So medical management, again, treatment of postpartum hemorrhage should initially use less invasive methods if possible, and if unsuccessful, preservation of life may require more aggressive interventions such as hysterectomy. So the medical management done are uterotonic agents, tranexamic acid, manual compression or tamponade or packing, and uterine artery embolization. So again, this is the medications given, the uterotonics, which was lifted from ACOG. So this is the first line treatment of postpartum hemorrhage. So tranexamic acid is antifibrinolytic agents, which is given intravenously or orally, and studies have shown that it has a significant reduction in mortality from obstetric hemorrhage, but has moderately reduced obstetric blood loss when given prophylactically. And risk of thrombosis was not higher in women who received tranexamic acid. So manual compression, tamponade, or packing is used when uterotonics and bimanual uterine massage fails to sustain uterine contraction and satisfactorily control the hemorrhage. So this is the table of the different types of tamponade that can be used. So we have commercially available intrauterine balloon tamponade devices such as Bakri balloon, abuterine tamponade system, and then we have the Foley catheter, which was the method used before when the commercially available intrauterine tamponade was not yet available. And then uterine packing, wherein 4-inch gauze can be soaked with 5,000 units of thrombin in 5 ml of saline, then inserted into the cornua to the other to the other with ring forceps. So these are the different tamponades used for postpartum hemorrhage. So this is the Bakri, the Ebb, and then this is the uterine packing. And then for uterine artery embolization, this is only done to specific patients who passes the qualifications. So the candidates for this are the following. The patient should be hemodynamically stable. There is persistent slow bleeding and failed less invasive therapy such as uterotonic agents, uterine massage, uterine compression, and manual removal of clots. This has a benefit of retaining the uterus for further pregnancy. So for the surgical management, we have three methods. We have vascular ligation, uterine compression sutures, and hysterectomy. So for vascular ligation, um, this is done when less invasive approaches, such as uterotonics, when the medical management is not effective. So this is done with via exploratory laparotomy, and then this is in the setting of vaginal delivery, the incision is done midline vertical, while the for patients who had undergone cesarean delivery, the existing surgical incision is used, and then the general aim for vascular ligation is in the setting of atony. It is to diminish the pulse pressure of blood flowing to the uterus. So a O'Leary's suture is a type of vascular ligation is usually done. This is done by bilateral uterine artery ligation. And then another type is the ovarian artery ligation. Then we have the uterine compression sutures. So the most common type of technique is the B-Lynch, wherein the sutures are placed from the cervix to the fundus, and it provides physical compression to the uterus. And then another type of uterine compression is Cho technique, wherein 4 to 5 squares of sutures are made from the anterior to posterior, while the Heyman technique is done by transfixing the whole thickness of the both uterus at the lower segment level, with the threading being passed over the compress to compress the fundus, and the thread tied at the fundus. So lastly, the hysterectomy. This is done when more conservative therapy have failed, and this is usually considered the most definitive treatment. And the disadvantage of this is it causes permanent sterility. Also, there is inadequate evidence in examining different surgical approaches to hysterectomy, whether to do a complete hysterectomy or partial. So that's all for the
very comprehensive report on postpartum hemorrhage. I couldn't have done it any better. Suffice it to say, postpartum hemorrhage remains one of the leading causes, albeit the leading causes of death in obstetrics, despite advancement of technology, and it does not pick race, although it has a slight predilection for some races. But in general, even if you are socioeconomic deprived or you are rich, there's a chance that you could have postpartum hemorrhage. Also, even if you're a G1, although it having a lot of children would have higher risk, even if you are G1, there's also a chance that you would develop or undergo hemorrhage. So remember your 40s, your causes of hemorrhage, that's your tissue thrombin, trauma, and your tissue, um, and your tone, um, and your classification of your hemorrhage according to your WHO, so that you would be guided into how to manage these cases. Okay, so always at the back of your head. Um, why did the patient deliver an non-institutional? Why was it a non-institutional delivery?
Doc, mas malapit daw po kasi sa kanila yung lying in clinic.
Ano?
Doc, mas malapit daw po kasi yung lying in clinic sa kanila.
Sa line inanganak?
Yes po.
Wait lang. Okay, and sa lying in nag-hemorrhage, ganun ba?
Yes, Doc. After daw, from the delivery of placenta, Doc, continuous pa rin po, Doc, yung kanyang bleeding.
Again?
From the, after delivery po of placenta, continuous pa rin po, Doc, yung kanyang bleeding until she went to the emergency room, continuous pa rin po siya.
So sa lying in, there was not a PCR or an antigen test done?
Wala pong hindi po yung patient.
Not noted. So,
Yes po.
there would also be a case of, again, it's a collateral damage of your COVID with your mother's receiving delayed care, etc., or more expensive care because of the pandemic. Okay? So, I think we had a fruitful discussion for this afternoon. When is our next reporting?
Doc, on Monday po.
Monday. Ano? Pwede bang mga 3 sa Monday? 3 o'clock?
Pwede naman po siguro,
Sige,
Doc.
3 p.m. na lang sa Monday. Ay, 5 kayo, no?
4 na lang po, reporters.
4 na lang. Sige, 3 p.m. is fine. Okay.
Okay po, Doc.
See you Monday. Shifting exam, kailan nyo gusto?
Kayo po, Doc, kailan po kayo available? Kasi hanggang Monday na lang po kami.
Hanggang Monday kayo.
Yes po, Doc.
Gusto nyo gusto nyo mag-report ng Sunday, mag-exam ng Monday? Or gusto nyo same day na lang? After reporting, mag-exam? Pwede rin naman.
Sige po, Doc. Ganun na lang po.
Sabay na lang. Sige, para one shot. Alright. See you Monday for your reporting and your exam.